most of the panelists here, so it's perhaps the right time to start. So first of all, good afternoon, and thanks for all the people being here on time. I know it's always challenging those type of conferencing, so I really thank you for that. So first of all, I'm very, very happy, of course, to share that panel. Very interesting panel, of course, for me. I think we all have seen recently, of course, lots of successes, to really make sure that we build capacities in terms of, medicine, vaccines, and we had a very, very good example and success, obviously, of what happened, in fact, to provide the right medicine, the right vaccines to support the pandemic. At the same time, I think everybody will be, I would say, very clear about challenges. Okay, we face massive challenges, obviously. And I think it's a wonderful opportunity, of course, to have this panel to talk about, the resilience of the supply chain in healthcare. How can we improve it? And share our experiences. I think the purpose of this panel, obviously, is to make sure that we share what we've learned, and we try to reflect on what can we do better, obviously. Okay, share different perspectives from different organizations. This panel is very, very rich. We've got lots of different organizations who play a very different role. So I will try to, of course, use the expertise they've got to try to understand how can we collectively move ahead, provide different solutions, and making sure that we learn from this absolutely exceptional experience that we faced for the last few years. As an introduction, also, I think I'm happy to be here because of my background, to be honest. Okay, so I'm from the private sector. So I've been working for the last 30 years in the supply chain area, how to improve the supply chain in healthcare, both on the private sector and the public sector. So I was the head of supply chain for many multinational companies in medical device. On the pharma, I was the head of supply chain for Novartis, for example. And I worked also on the public sector. I was the head of supply operation for the Global Fund for a few years. So I think for me, it's critical to share information and try to build those bridges between the private sector and the public sector to make sure that we can collaborate, to try to build capacity, quicker into the market. And I think that panel is going to help us to try to understand how can we do that together and share those experiences. BD is a company, of course, who has supported the pandemic a lot. In fact, we supply to the market millions of syringes and needles. We had to change, of course, our capacity very, very quickly to adapt and to produce, of course, COVID tests, for example. But locally, we're not the only one. Lots of companies have been able to do that, of course, to really challenge themselves, change their network, and start to provide solution in a very, very limited time, with a certain level of risk to be able, of course, to answer to that pandemic. So I think that's something that we've learned, and I think we've tried to do that the best we can. We were not the only one, of course, in the private sector who's done that. Organizations help us a lot, in fact, to go after the distribution, okay, to make sure that we had the right distribution channels. And I think it's going to be super interesting for me to ask different organizations their experience and help us to understand the way they did it, and also the type of challenges that they faced, okay, to make sure that we can put that on the table and think about collective solutions. So based on that opening, of course, I will ask first question to organizations which were in the middle of the pandemic in terms of supply. I will ask, in fact, the first question to Eva. So Eva from UNICEF. Good afternoon, Eva. Of course, you've been in the middle of this crisis. In addition to that, of course, UNICEF is a member of Act A, okay, which is playing a key role in terms of the coordination of the supply. So I would love to have your opinion about what works well and what didn't work so well. What are the challenges that you face?
Thank you so much for having me here. And really, it is such a pleasure to share our experience and what has happened throughout the pandemic response. UNICEF, just to put a little bit on the context here, we have been actually over 7 decades actually that we are supporting into different health emergencies and other emergencies as well, and crises that are ongoing in support of the child rights agenda. And of course, as we faced the pandemic, we were building on our strengths and capacity and leveraging really our network, being this global network of partners, of donors, the global network of industry, private sector, but also leveraging exactly what is also our strength, the boots on the ground, so our footprint in 190 countries. And that was really critical with regards to our ability to respond fast and quick. Over these decades that I was mentioning, we've been supporting global response also of other outbreaks such as swine flu, the polio, Ebola, Zika, and of course, COVID was really unprecedented. And with always the focus to build building on strong existing partnership and building resilience at the country level as well. Our focus has always been end-to-end. We heard the previous speakers from the previous panel focusing, and it was great to hear this today at today's discussion, that end-to-end came quite strongly throughout the discussion. That means that not just really looking at securing access to commodities, but also making sure that the delivery is done fast, but also making sure that it's not just about COVID response, it's also routine response, it's also multi-sectoral response. It was not possible to respond to COVID just giving tools such as PPE, diagnostics, COVID vaccines without really responding with regards to sanitation. We know how important it is hand washing with regards to the COVID response overall, but also nutrition, access to water, and also during all this disruption as well, access to education. So it is so important to look at this holistically in terms of how we've been trying to respond. But also a key, I think, important lever would be the engagement with community. We also heard from the previous speakers the engagement at the local community and using not just, as we spoke about, tools such as, with partners, as with Google and Meta that we've been collaborating, really trying to understand through the social listening, through the community engagements, what are their issues, what are their hesitancy with regards to acceptance, and trying to really understand the challenges for taking this forward. I think in terms of overall challenges we've been facing has been absolutely access. And that means the equity for UNICEF is very important in terms of really end-to-end equity. The investments that have been made, especially on the R&D, was so successful. We saw a lot of innovation coming to market in terms of speed, but that equity in terms of making sure that that product innovation that is coming to market is really fit for purpose for the context that we are working with. It is also so important. So it's so important to really influence that from the onset of the R&D agenda, because I'm saying this because a lot of efforts we've been doing in terms of building the infrastructure of immunization, such as cold chain, for example, or existing stockpiles of syringes, needles, cold boxes, and so on. But then the new innovation that came with vaccines required totally different new infrastructure of ultra cold chain. And that meant that we had to really recalibrate and make sure that we could support countries with the speed that was needed to bring to the last mile these vaccines that needed totally different new infrastructure. But also when we talk about end-to-end, let's not just focus on tools, which are, the COVID tools alone. We also need to focus on human capital. It is so important, the training of health workers, and that's what we've been trying to support in parallel as we're trying to make to ensure access to the commodities, but also trying to train the health workers doing the micro plans at all levels of the health system, not just at the national level, but at sub-national level, district level, up to the lower level of community. And this required totally a new different system of delivery, which normally wasn't there as a platform for delivery for adult population. That really required all hands on decks for mobilizing the entire health community. And I would say here, it has been really tremendous efforts for putting in use and really leveraging the capacity. We're very thankful for leveraging the capacity of polio health workers. So some of these learnings that is very important to keep in mind, that those investments such as the polio health workers that existed were really put in use during this emergency. And we need to keep that in mind in terms of human capital and how we can bring that forward in times of emergencies. And finally, to conclude, because I'm sure we'll be talking and unpacking a little bit of all of this, what helped us and served us in the beginning was absolutely a stockpile that we were keeping at the global level with regards to syringes, to needles, with regards to cold boxes and so on. But of course, we were not prepared for the scale of COVID at that scale that we all saw. And that was really, really challenging. So I think that has been felt in terms of, I'm talking in this case about syringes, because sometimes the entire focus has been so much on vaccines, but it really requires an entire infrastructure and other, ancillary products that are needed, and training and so on, that you need to have in place in order for you to roll out and make sure that you have the last mile, the storage capacity, and everything in place in order for those vaccines to turn into the arms of people. And I'm not going to talk about other tools or other interventions, because of course at the same time other outbreaks were also going in parallel, such as measles outbreaks, and we had Ebola happening also in DRC at the same time as COVID, but we also had innovation taking place, such as malaria innovation. So quite fascinating times, a lot of learning that I think we'll be unpacking a little bit later. Thank you.
No, thank you very much, Eva. I think a very, very good perspective. And if we have some time, obviously, to come back on the end-to-end, I think that illustrates very much capabilities would be super interesting, and the stockpile and the scale. So thank you very much for that perspective. I would like to move to you, Najat, if you don't mind. I mean, you belong to the International Atomic Energy Agencies, and the IAEA was really keen in mobilizing, of course, PCR machine to scale testing around the world quite quickly. So help us to understand what was the challenges that you face, of course, and the opportunity that you believe are in front of us to do that even better in terms of scale up.
Thank you, Francois, and good afternoon, everybody. I think many of you are wondering why the International Atomic Energy is here. We are not talking about the safety and security of nuclear power in Ukraine, but I don't know if many of you, you know that we are offering Atom for Peace and Development. And for many years, more than 60 years, my department has a division on human health where we are covering the entire spectrum of human health, from the diagnosis to treatment, nuclear medicine, radiotherapy, radiopharmaceutical production, which was under tremendous pressure during the pandemic. And I will come to that question later on. On the pandemic itself, we have joined program with the FAO. And in that program, we really look at how we can offer the technology to address issues related to the food security, but also to zoonotic diseases. We were helping member states for more than 60 years. And when the pandemic triggered, member states turned back to us asking for help. 130 countries wanted RT-PCR and wanted training how to use these RT-PCRs. So we did, and we supported more than 300 laboratories immediately. I agree, like my colleague from UNICEF, we were facing the challenge of the supply chain, and we were part of the CMT task force. But nevertheless, we have also a system in place that was efficient enough to also try to supply. However, we were asked why this is happening, why member states were not ready, why there is no capacity on the ground to be able to detect. And that's why we immediately launched an initiative called Zodiac. I don't know if some of you have heard about it, which is Zoonotic Disease Integrated Action Plan. And the idea is really to build capacity on the ground, is to train people. This is missing, how to use technology, how the biosafety aspect, but also this network, sharing data, sharing the standard operational procedures. There is no discussion. Everything is on silos. And joining the CMT was for us also open eye, because we knew what everybody is doing, and we knew that we each one of us has a niche. and we are complementing each other. This is very important. And on the ground through Zodiac, we also were doing what maybe others are doing, but we were doing it for 60 years. So we were just going there and enhancing the capability of this network. Because what we have noticed is that institutions are passive. They react at the moment when we were hit by the pandemic. But we need to be more proactive. We now experiencing monkeypox. We don't know what is coming next. So we need to be more proactive and focus on science, technology, on research. And this is what we heard today. On IT technology, we have been training thousands of people through digital learning, through e-learning, because we could not go to the countries, we could not have face-to-face. And on the health side, we ran a survey on the access to nuclear medicine and to radiotherapy, particularly in low and middle income countries. The access was below 50%, which means that those that they need treatment, they could not have that treatment, and particularly in countries, for example, in Africa, that they were already under pressure and they had limited access. And that's why we created the initiative of Rays of Hope, is to scale up. We need to ease down the pressure on health system to make everybody having access to diagnosis, to treatment. So when we have an emergency, we can at least have other centers that they can continue delivering services like to maternal child health or to infectious diseases, to diagnosis and to treatment. I'll stop here and maybe I will come back to more details later on. Thank you.
Thank you, Najat, to share with us, of course, the necessity to build those networks, to use technology, of course, to do that, and to make sure to do that in a very proactive way, because we know that being reactive sometimes is not so efficient. So thank you for that. I would like to turn it now to Pierre. So Pierre, I think you belong to the Health Emergency Preparedness and Response Authority in the European Commission. So the key question for me is really to talk about I know that you're working hard on the preparedness plan, response plan, of course, from a European perspective. The question I'm asking myself, why do we need those type of organization, and what do you want to achieve, in fact, in terms of coordination? Can you develop that for us a bit more?
Yeah, sorry. You see, thank you very much, Philippe, for your question, and thank you very much for having invited me here. I know Hera is a little bit a strange animal. I've already got a lot of questions. What is Hera? It's a Greek goddess, but it's not only a Greek goddess. It's also a new authority. So a lot of questions, and maybe not all the answers at this stage, because we are still very new, and we are still in work in progress. So why Hera? Why are we there? Why have we been created? Because again, if you look at the lesson of the COVID crisis, we need to put those lessons into action. Talking about the lessons is very good, but also making concrete action is also extremely important. What have we learned during the COVID crisis? Many things, and many things have already been said. But first of all, as you said, Naja, being proactive, trying to anticipate on future crises is important. What does it mean, anticipate? It means trying early detection of possible health threat. But detecting possible health threat is not sufficient. You need to put in advance medical countermeasures which will be there to try to help. So that dimension is the first lesson that we need to put into practice. Focusing on early detection, putting into place measures to try to counter those health threats. That's the first element. Second element, what have we learned also during the COVID crisis? That working in isolation does not work, actually. If you live in isolation and you try to close border, it does not work. The only way to find solution to future health pandemics is by working together, by coordinating in Europe, but also outside of Europe. So ERA is there to organize a cooperation within Europe, but also we have an international dimension, because it would be also stupid to believe that you can close the borders to the rest of the world. I still remember when the first cases of Omicron were detected, in South Africa, And people in Europe were still saying, "Oh, the COVID is gone, it's gone, it's gone." And then it came one case in Europe. I still remember, end of November, one case in Europe, and in a few weeks' time, it was everywhere. So we need to understand there is a global dimension to health threat, and so HERA is also there to work in that health dimension. So concretely, what does it mean? It means actually that we have a budget, we have people, and we want to create network of resources within Europe, but also outside of Europe. Because as you say, we need to take into account, we need to bring on board, also developing countries. We need to bring on board everybody because health threats are global. As I say, I don't want to repeat myself. So what does it mean concretely? What have we been doing so far? For instance, we have been working, of course, we are now submerged to a certain extent by the COVID crisis and monkeypox, which is taking a lot of resources. But as I say, we are working on creating a platform, electronic platform for early detection of future health threats. But again, it will not be open only to European. It should be something which is global, where everybody has a chance to participate and to take part. And we are financing it. We are working on, medical countermeasure. You mentioned, for instance, the question of, stockpiling. Stockpiling is important. We need to have, appropriate stockpiling. Otherwise, you will not be ready when there will be a crisis. We are working also on a project which is called EU Fab. What is it? It's simply just reserving production facilities in companies. Not using them if you don't need, but if there's a crisis, to be able to go to those companies and to say, sorry, guys, you stop doing what you do, and now you produce what is needed. Because during the COVID crisis, we saw that it was extremely important, this possibility to switch production and to move quickly to a new type of production which was needed. We want to have this possibility in the future, so we want to reserve those production capabilities. And finally, maybe to conclude, as I said, we are open, we are talking to the rest of the world. We want to talk to the rest of the world. WHO, of course, is a very important partner, but also in different countries, in different parts of the world. We have already concluded agreement with the US. We're in talks with other companies, because again, one key aspect is what we do in Europe should be also useful for the rest of the world, and we don't want to do it in isolation. So I would stop here, because otherwise I would have been too long and you will switch me off.
We'll not switch you off, don't worry for that. But thank you very much for the perspective here to help us to understand a bit more what HERA is doing, and the key focus on collaboration, cooperation, and at the same time trying to understand capacity worldwide, coordinate capacity worldwide, which obviously is one of the critical topics when we talked about supply of healthcare. That's very clear. And that's a good transition for me to go to you, Petro, of course. Okay, you belong to African Biologics. And of course, we talked a lot about manufacturing capabilities. How do we delocalize? How do we basically continue to have different suppliers? So, I mean, you belong to a very, very new organization, okay, which has the aim potentially, of course, to build, research platform, manufacturing platform, and delocalize that very, very close to the market who needs that the most. Help us to understand exactly how do you intend to do that?
Okay. Thank you very much for the opportunity, and thank you, Philippe. Before I go to the how, maybe can I share some thoughts? The last mile cannot be completed if the first mile is not run. And if I take you to my continent, Africa, a continent that doesn't have the ability or the capacity to produce the routine vaccines that it needs for public health, would be very, very difficult to respond to a pandemic. It will be impossible for this continent to receive technology, or for this continent to innovate around vaccine manufacturing. So this pandemic has again demonstrated the importance of a decentralized manufacturing system that ensures access. The mRNA Hub program is a fantastic example of leveraging unconventional partnerships. Under Act A, COVAX, CEPI, World Health Organization, Medicines Patent Pool, governments in Europe and in North America coming together to resource a program that has a goal to build capacity, capabilities for a future relevant vaccine manufacturing platform for low and middle income countries. This program had to start from greenfields to develop own technology, own platforms, building facilities, produce all the quality control, quality assurance necessary for an effective technology transfer to 15 other countries and low and middle income countries. 5 of those countries are part of the G20 group of companies, group of organizations. How do we do that? Partnerships. This is the first and most important component of what we've learned. Building the partnerships and allowing partnerships to resources to advise us and to capacitate us. Secondly, just when we thought it's impossible, we realized that it is possible. We leveraged pockets of scientific excellence and technological knowledge on the continent to fast track the development of a COVID-19 vaccine, an mRNA COVID-19 vaccine. This is a product that will be used to validate the platform, because what this program is about is to demonstrate that vaccine manufacturing capacity is a socio-economic imperative, that by building the capacity and the capability for regions to produce their own vaccines will capacitate those regions to build sustainable systems for pandemic preparedness, but also to utilize these platforms for socio-economic development. There are few imperatives that has the multipliers of vaccine manufacturing into a socio-economic system. The economic multipliers are vast. It is skills development, it's job creation, innovation, direct foreign investment, restore the balance of trade, building the capacity to innovate, building value chains, contract and attract direct foreign investment, and positions countries and companies to build partnerships. This is a one world approach, not a north or a south approach, but a one world approach. So how will we do it? We do it through partnerships. We do that through pockets of technological excellence. We build a platform that will be suitable for multiple products because it has to be competitive. It has to meet all the quality standards, and it has to be sustainable. And the only way to do that is for multi-product systems. So we require an ecosystem that supports and understands the very important socio-economic imperatives of local manufacturing. Thank you.
Thank you very much, Petra. We do have Sulaiman online, okay, from the Gulf Health Council. So Sulaiman, you've heard about, all those initiatives on the manufacturing side, but I would like you to have your perspective on the regulatory side of it. Okay, manufacturing is one side, of course, but we need at the same time to build all the regulatory capabilities. So can you basically share your experience in this area and how do you see it?
First of all, thank you, Philip, for your introduction, and thank you for the organizer for invitation to participate in this Health 20 Summit as part of the G20 health work streams. First of all, I will give a small introduction about our organization and how we are cooperating with the 6 countries in the GCC. We are mainly handling and coordinating several functions in terms of health issues and the health medical supply and the health supply chain is one of them. We are conducting more than 18 tenders in a yearly basis for all the 6 countries to provide healthcare, vaccines, medications, medical supplies, and we are awarding the companies with more than $2 to $3 billion in a yearly basis for all the 6 countries together. And what we have been facing during the pandemic is what happened to all the world in the last 2 years, which is a huge challenges in terms of availability of the products and the health commodities and vaccines. In terms of planning and organizing, I could say that the major challenges we are facing during the last 2 years, it's come in 3 categories, which is the prepared and the development and the monitoring. Even though we have building and conducting the tenders for all the 6 countries, and we have a plan for strategic storage with all the 6 countries to be monitored and developed and tracked, but still we face several challenges. And we could notice that the challenges is that even though we have a plan, but this plan is not have been worked well once the pandemic has happened. And we have several reasons for that. Also, in terms of governance and policy, and which has been highlighted, Philip, is important and crucial. And this is it's out of our control as a health as a health expert or as a health worker, but we have to address and work with those who make these policies and regulations to be easy, and making sure that the supply, the continuity of business in the healthcare system is working well and save the life of the people. In terms of also, we have more than 500 to 600 line item, which is already defined as critical to be available in the storage. But once the pandemic happened, this 500 to 600 is not fully available for several reasons. Also, in terms of developing, and I think so, it's one of the most important things is developing the strategic inventory, not only in the supplies, but also in the vaccines, medicine, spare parts, and the raw material also. In terms also, we linked what we have facing is also the development of the human capital and the technology. We have to admit that we have a lack of human expertise in supply chain, in planning, storekeeping, as well as forecasting. And this one, it could be resolved by developing the technology in terms of forecasting, the GIS, geographical information systems. All of this, it could be as part of the solutions. And finally, also, and which is the most important thing, is that when I talk about the tendering process for all the GCC countries, we know that from a long time that's almost between 70 to 75% from all the supplies we have, it's come from outside these 6 countries. And it's critical, and we have to think about it, how to localize and develop our local manufacturing, as well as international marketing, invite international marketing to build their factories in the GCC countries to assure the high-level access of the products, as well as timely availability. In addition, I would like to highlight in the research and development, which is need for as a big challenge, and this is need to be invested and work with all the local manufacturing and the universities as well as. And finally is the monitoring. Monitoring is the most important things, that all the plans should need to be monitored and enhanced in order to make sure that it's went well and continuous development. Thank you, Philip.
Thank you very much, Sulaiman. I mean, I would like to build on the last point you made about, of course, the logistic platform, the local manufacturing, and the distribution capability. And I would like to ask you, David, in fact, from Medicine for Malaria Venture, how do you think, of course, the localization of manufacturing will help, of course, the Medicine of Malaria Venture to basically eradicate malaria?
Well, thank you. So MMV was formed initially as a product development partnership, and we've been successful in bringing 11 products through to market. We pretty rapidly learned that a compound isn't a medicine until it can get into the mouths of patients that actually need it. And so supply chain management was absolutely crucial to what we do. During the COVID pandemic, we were alerted really early that things weren't proceeding as they should. And so in February of 2020, we got a call from one of our generic manufacturers saying that they couldn't get the key starting intermediates for what was the most widely used, or is the most widely used and produced malaria medicine. And then when we mapped the supply chain, we found that multiple other manufacturers of the same drug were having the same problem. And beyond that, because many of the drugs are from the same classes, that the supply shortages were impacting multiple drugs. So effectively, we were having single points of failure occurring. And it was jeopardizing the entire supply chain. So on the basis of that, we thoroughly mapped the supply chain and began working with our manufacturing partners, both innovative and generic, and with WHO, who were key in contacting countries to unblock some of the blockages we've identified. And then they were also instrumental in setting up a forum where we could work together with partners to identify bottlenecks and begin to troubleshoot. the supply chain was impacted in a number of ways. So there was the direct impact that we've just mentioned, but there's also competition. So this was seen in the development, in the production of malaria rapid tests, rapid diagnostic tests, because the same companies were then called upon to make COVID rapid diagnostic tests. And so you effectively had a shortage of the malaria tests that were needed, which put us in a pretty precarious position. Sorting out the manufacturing issues was one thing, but then we had global supply and transportation disruptions that needed to be managed. And there doesn't seem to be any mechanism for the prioritization of essential medical products amongst the movement of goods when, for example, higher value electronic equipment and chips may actually sustain the types of price increases that are required to move them around the planet in preference to medical goods. And so there are a number of issues that went beyond just manufacturing that could require attention. One of the things that we've been doing is just acknowledging that there needs to be far greater resilience and redundancy in the supply chain and far, far better planning. And as part of that, what we've been doing is supporting local manufacturing, particularly on the African subcontinent, where 90% of the anti-malarial drugs are actually used. And we're very pleased to say that within the last week or so, Universal Corporation Limited in Kenya has received WHO pre-qualification for an important malaria medicine. And I think we're really heartened also to see some of the work that's being done by Afrigen on the vaccine side, but also the recent announcement within the last 72 hours by Aspen Pharmaceuticals and the Serum Institute of India on moving meningococcal, cryptococcal, and rotaviral vaccines into Africa for local manufacturing. I think this is a tremendous move that will ultimately benefit us all. And just sort of a closing remark on that, prior to entering the NGO sector, I worked at Roche and I was involved in pandemic preparedness. And in looking at oseltamivir, one of the things we did was we made sure that we had full manufacturing end-to-end on multiple continents because we view that that's what was required in order to give us the type of assurance and resilience that was required. And we need to be looking beyond individual companies and have a geographic perspective on this. Thank you.
Thank you very much, David. I think you articulated very well, of course, this need to look at planning at the end of the day, not only just, manufacturing capacity, but starting to think about, distribution capacity, then transportation capacity. And at the end of the day, to look at the three components, which are always the same one, which is the plan, the source, the make, and deliver. So based on that, I would like to come back to you, Eva, because of course, end-to-end was basically what you talked about at the beginning, and the need for planning end-to-end is absolutely crucial. So how do you see that in the context of collaboration?
Thank you so much. Yes, I think it's important to mention first that I don't know if I should say thanks to COVID or not, but the reality is that there is finally a focus on supply chains because it was taken for granted the supply chains will work, you'll have the milk in the fridge, but it didn't work like that because everything was disrupted end to end. And also there were many other challenges, including barriers to access, such as export bans and so on. So you can have a perfect plan that is really perfect. You can have a perfect forecast, but then suddenly, if you're facing a barrier of access, which can be an export ban, then how are you going to operate? And that's what we faced during COVID. This is what happened. We also learned that unless you have a controlled inventory that is under your controlled inventory, not at the manufacturer, actually. And therefore, I'm actually highlighting this, the stockpiles is very, very important because that allowed us to still continue to deliver despite the export bans, because that controlled inventory was secured as a stockpile under UNICEF's global stockpile management in the headquarters where we keep. So that was also second very important lessons learned. And third, what we saw is that, of course, it is so important that the the last mile, all distribution plans should, be looked very detailed, because you might also think that you will have local production, but interdependencies on raw materials also told us that even though you have a local production somewhere, you might still not have access because manufacturers were not able to get some of the raw materials to do their production. So many interdependencies. Still believe that focusing on local manufacturing, focusing on regional manufacturing, looking at this from all aspects, global, regional, and local, really with all dimension of end-to-end, from really good forecasting, planning, distribution, storage capacity, but also having that commitment in terms of really what the previous group was discussing about, in terms of intergovernmental commitment to allow for access to raw material, will only then be successful to make sure that we are delivering. Also, we will need financing at risk. Some of these stockpiles need to be put with some financing at risk. So that's the only way also for us to respond. The other thing is regulatory. So we tend to forget that there is an entire ecosystem that needs to enable also regional and local manufacturing, that needs to support that production is done of quality and meets standards. And that ecosystem needs also to be supported. I think what we are seeing actually is it's really fantastic news, what we are hearing these days. We have had in Africa, and we are supporting production of vaccines such as yellow fever, for example, out of Institut Pasteur de Dakar in Senegal. And we are looking forward to more production in Africa, but not just only vaccines. We have to look at all other essential commodities that needs to be at least secure for ensuring health security, not only at country level, region level, that is going to contribute to the overall global health security level. So that, looking at that picture globally, I think is very important. Therefore, partnerships are so important, because we can't look at this in isolation. It has to look based on partnership all together, partners, donors, governments, of course, private sector is absolutely instrumental, and civil society and international organization. So those were some of the things I wanted to share. Thanks.
Thanks very much, Petra, for this, I would say, stressing the importance of the planning, of course, on every single component. So thank you very much for that. We're just 15 away from the closure of the session, and I would like to make sure that we're going to do a simple exercise, which is, I think, a critical exercise. Okay, I'm going to ask each panelist, of course, to just answer with 1-2 minutes max about what would be the #1 investment on the #1 improvement that you recommend, which, in your point of view, will make a difference. Okay, to really strengthen the resilience of the supply chain and making sure that we can collaborate even more to bridge the capacity that we need, of course, in a pandemic situation. I will ask with you, Petra.
That's very unfair. The one investment for the biggest impact.
Correct.
So I'm back to localized manufacturing. I think the plea to the G20 summit coming up next week is for governments to very carefully look at the socio-economic impact of investment in local manufacturing. And that does not mean that it's not a competitive process, and it may mean that we will have to pay a premium for the first few years on products produced locally. And that is not an unprecedented situation, because the global north have built industry on early subsidizations and support. Support local manufacturing in low and middle income countries in a strategic and carefully designed way of portfolio of products essential for healthcare in these regions. And this is not only vaccines, it's also other essential health products.
Thank you very much for that. I will go on the other side of the room and we'll ask Pierre, what would be this single investment, single improvement that you will recommend?
Thank you very much. I don't see the logic of moving from one side to another side, but anyway, I would say simply one thing which is important. I'm not going to repeat what has been said. We need to know better what's happening. Because that's, as we say, we don't know actually how the supply chains are functioning. We don't know everything. So increasing the transparency, having a better knowledge of what exists or does not exist on the ground, I believe is something which is very fundamental. If we are not able to increase this transparency, and I say we are working on it also with, using data, digital instruments, we need to do it. We need to increase this. And maybe one last point, since probably the last time I have the opportunity to talk, but let's link to what we are discussing. We are still not very far away from the COVID crisis. Actually, we are still in the COVID crisis. But clearly, there are other crises which exist. We have Ukraine, we have energy, we have things and so on. So the risk, I fear, is that simply people will forget about the health issues and will focus on something else. And why is it a risk? Simply because in 5 years' time, 10 years' time, we might be faced with a new equivalent COVID crisis and we will not be ready. So my message also, and that's linked to what you say, is it's important that the attention is still there on health issues, because otherwise we will not solve the next crisis.
Thank you very much, Pierre. Najat?
I would say focusing on human capacity at country level, increasing capacity particularly in low and middle income countries, so that they can, particularly at the upstream part where we are looking at surveillance and what is happening at the country, and in research and innovation, so that we can have better tools for detection, particularly of pathogens, and accessible to countries. We heard today that yesterday, actually, health for all, but also health with all. So we should be inclusive and give a voice to low and middle income countries. Thank you.
Thank you very much for that. I will go for, of course, the only panelist online. So I would love to have your perspective, of course, Solomon. Solomon, can you hear us? I don't think we can hear you well.
Yes, I'm hearing you. Thank you.
Okay, go ahead.
I like what has been done with my colleague, especially Mrs. Petro, when she would like to develop the local manufacturing. I totally agree with a specific rules and rules for them. For example, guarantee the quantity from the government for them, as well as availability of the raw material and the access to the raw material. And also, I would like to add, with what have been my colleagues add, is the research and development is important, as well as developing the information technology in terms of GIS technology, inventory systems, especially for the low and middle income countries, in order to have a better planning and utilization of the raw materials and medical commodities. Thank you.
Thank you very much for that. So I will basically do the same exercise, and the next one, David, is for you. So single investment, single opportunity.
Okay, well, so firstly, I'm really happy that that our colleague Petra Terblanche spoke first, because fully agree. So that's my one out of the way. I don't have to repeat it. So lessons learned. So we need to make sure we do it the right thing next time, and I think that's the wrong approach. We've learned a lot of lessons, but there are testing grounds that we can use today to move and make improvements. So we've got HIV, AIDS, malaria, TB, neglected tropical diseases, and many of the issues that we're discussing today have been impediments to progress in those areas. So why not intensify our efforts there, help solve those programs, and at the same time, what we can do is ensure that we have the right structures in place next time we address a pandemic.
Well, thank you very much for stretching the structure, the coordination. I think that's a theme which has been, of course, one of the critical one in terms of planning, in terms of the capacity to coordinate and making sure that we do that end to end. So Eva, you're the last one where I'm going to ask that question, of course, about the single improvement, single opportunity, or single investment.
Great, thank you so much. Again, I also would like to say that I fully support what Petra said, so I'm not going to repeat that. But definitely, I want to say that we should move away from vertical investments, such as just health. We've been talking about, silos approach, and health issues of health are not isolated to health. We need to look at strengthening primary health care, approaching it through the multi-sectoral approach. And so that would be my call for investments, if these recommendations are going to the G20, that we look at the investments that are going to strengthen the primary health care with a multi-sectoral approach. That is the only way for us to fight any disease outbreaks. Thank you.
Thanks very much, Eva, for that quick summary on the critical ones. Then it's time to close the session, obviously. And before I close that, first of all, I would like to thank all the panelists about, the openness of discussion and helping us to understand the complementarity of all those organizations, and stressing, of course, the need to work together on the planning, on the end-to-end, basically making sure that we can share, of course, our capacity and thinking about what matters in the field at the end of the day. I think, as you said, COVID was, of course, very, very difficult, very challenging, but it was an opportunity to stress those needs and to create the structure, to generate the funding, to create the coordination mechanism, which can help us, of course, to that better, in fact, on the long term. And I will hand it over to Heike to close the session.
Thanks, Pierre. Thanks for having me. I'm here on behalf of Charles Gore, the Executive Director of Medicine's Patent Pool, who unfortunately couldn't be here today. So, it's been such a privilege listening to the panel here today. The experts have definitely brought in some ideas and lent their experience on how supply chain and manufacturing capabilities, especially in the low to middle income countries, can be strengthened. I think collaboration has been a core term that has been throughout the panelists today. Another core point is that COVID certainly did leave a legacy that we can learn from, and where there are things that were done quite well there, but there were also certain weaknesses and vulnerabilities that we saw, especially in terms of supply chain. So we've discussed that local production is definitely key for going on to the next step in empowering the local regions to ensure that they have the ability to address the next pandemic. The idea that David was saying in terms of applying our learnings from COVID to the disease areas that are currently existing is definitely a key point that we can take forward. Altiva, you were mentioning leveraging the public and private networks, taking that forward, growing these partnerships. Not only for COVID, but for our routine responses, medicines and nutrients, taking a holistic approach and engaging with the communities to get a full understanding of that was also really key. Human capital development, making sure that we have the skills, being able to deploy those skills in the time of need, also really, really key. We also talked about the logistics, the complexity that these vaccines have. They cold chain, some of them minus 20, some of them even minus 80 degrees. And this was something that did have challenges. And so another point is really working on our research development and innovation, and perhaps even looking at technologies that don't require that level of complexity going forward. Early detecting and monitoring, very key. So building on that, having early warning, not working in silos, working as a global force, not potentially a north versus south or north and south, but in community inclusive. So I think those were the key main points that were discussed today, and it was really good being part of it. Thank you.
Thank you very much. And I would like to just thank everybody for the very good debate that we had, the engagement and the level of transparency, and to basically manage the debate. Thank you very much, everybody. Thanks.
For moderating this session. Yes, now the microphone is up, and as you can tell, we're already doing this lineup here again for another fireside chat here right in the middle, this time a bit bigger, and I'll be joined by my speakers, whom I kindly invite up to join me here in the circle to discuss and pick upon what Philip and his distinguished panel has been speaking about. For the next 30 minutes, we'll take a deeper dive. Want to ask my panelists once more, for those who will be speaking in this session, just come up and join me. There are Lord Herbert, of course, who is the chair of the Global Tuberculosis Caucus. Peter Krustrup is actually joining us live. Yes, please have a seat. Can I ask Lucica, Dicu, Konrad, Reinhard, and Ricardo is already with me here. Great to see you, Ricardo. Right. So from what I can tell, there are two speakers still missing. Wonderful. Excellent. Good to have you. Please have a seat. And that just leaves us with one missing speaker, and I can already see, yeah, is coming. And while our last speaker is making the rounds, let me say this is a fireside chat, 30 minutes. So it's relatively short, but I'm hoping to manage and squeeze in as much as we can. It is titled, Why Do Some of the Biggest Killers Worldwide Don't Receive the Attention They Deserve? Obviously something that our previous panel picked up on. And we have joined here, of course, we're joined here by Lord Herbert, who's leading the Global TB Caucus as the chair. Joining us live virtually is Peter Krustrup. He's a professor of sport and health sciences at the University of Southern Denmark. Great to have you with us. Lucica Dicu is here. He's the executive director of the Stop Tuberculosis Partnership. Konrad Reinhardt, the founding president of the Global Sepsis Alliance. And certainly last but not least is my friend Ricardo Baptista Leite. He's the founder and president of Unite, the network of parliamentarians against infectious disease. Lord Herbert, let's dive right into it. Some of the biggest killers don't receive the attention they deserve. That's certainly true. That was certainly true before the pandemic. That was certainly definitely true during the pandemic, when everyone's mind, in terms of health at least, was pretty single-minded. How do we bring this attention back? If we're looking at the number of deaths staggering, why is the media, why are politicians, why is the public not seeing this?
Well, I think TB has always been the orphan disease. The pandemic that up until COVID was killing more people every year than any other infectious disease, but wasn't noticed, especially in the Western countries where TB wasn't prevalent. And I think that actually most members of the public, most politicians in those countries thought and think that tuberculosis is beaten. And when 15 years ago, I was sent on a trip down to Kenya as a newly elected member of parliament in the UK to look at HIV, AIDS, and TB, I put up my hand in the first briefing in a hospital in Nairobi and said, but why aren't you vaccinating people? Because in common with many parliamentarians, I'd not read my briefing. What I saw was upsetting about what was happening there, and a group of us went back to the UK Parliament, set up a committee to campaign and to draw attention to tuberculosis. And the thing we discovered is that almost all of our parliamentary colleagues did not realise that tuberculosis was a current issue. And I think we who are closer to it now can lose sight of the fact that politicians may know that HIV/AIDS is an issue still, that malaria is an issue, but many politicians think that TB has been beaten and that there is a vaccine for TB, which we know isn't the case. COVID clearly has, as your question implies, accelerated in the political consciousness the importance of global health security. But there is a danger that we still present the arguments as a kind of either or, and we shouldn't. We have to locate the arguments for beating the existing pandemics, including TB, in the arguments for ensuring resilience and beating future pandemics as well. And that, I think, is particularly when nations are resource constrained now, which they are massively because of the impact of COVID, now the oil gas price shock as well, that we have a double challenge now to persuade countries to act. We won't do that unless we talk more generally about global health security.
Lucica, if I'm looking at the numbers provided by the WHO, cardiovascular disease currently the leading cause of death worldwide, with almost 18 million deaths per year, while infectious diseases such as TB, 1.5 million deaths in 2020. These still remain the leading cause of death in low-income countries. How can all stakeholders in this room and beyond work together to tackle this issue and focus on zoom in on these diseases and bring it the attention that they deserve?
Yeah, so thank you so much. It's, I think I'm a strong believer, and Nick here, that, and I probably a lot of you in the room, that when there is a will, we will be able to do it, okay? We showed with COVID, right? Development of the tools, the rollout, the vaccinations, all these things, right? And any normal person on this planet will say, why are we not doing the same with the other diseases? What is the right answer here? There is no will, because otherwise it is possible. And we saw immense amounts of funding being discovered. And even the countries that are the lowest income were able, with support of donors, with their own budgets, to put live data for COVID, right? We don't have live data for TB. We don't have live data for HIV or so whatsoever. Of course you shit your pants, sorry for my French, and you want to activate everything when you have the COVID data on every single screen, by gender, by age, by whatever, by district, okay? We don't see this with TB. We don't see that with HIV. We don't see that with cardiovascular or cancer, right? And it doesn't mean that we should crazy go and fight just TB everywhere. It has to be, what is your biggest killer? And I come from a country in Africa in which TB is 3 times killing more than HIV, and kills more than HIV and malaria together, but people are still oblivious to that. So, but you didn't ask me to speak about data. You asked me, what can we do? And Nick allured to that. And somebody in the previous panel said, let's stop with this vertical funding. You see, and I speak about TB. TB is traditionally, people will say, oh, these vertical people extra medicalized. Well, actually, in the last years, there are a lot of tools. And because we are so poor in TB and lacking attention, we are trying to do a lot and across and multiplexing diagnosis. And it went very well in some countries with COVID, in which, you have 2 airborne diseases, right? COVID and TB are airborne, okay? They are spread through air. It goes through the nose, it ends up in the lungs. Let's be very honest. Any future airborne disease will operate in the same way. So why don't we invest in creating the systems, if we want to be prepared for the future, that will help us with TB, but will help us with COVID, H1N1, epsilon gamma, and whatever things might come in the future. So investing we are now pushing from Stop TB, and we see this taking a lot of speed now, for portable diagnosis tools, including X-ray, which has also including artificial intelligence. X-ray can be now very miniaturized. You can take a selfie with it. Don't recommend, but you can. And then you don't need a doctor to read your photo, is the artificial intelligence. And you know what? When you do that, you don't discover just TB. You find pneumonia, asthma, COPD, but you find even also cancer. And actually, in a country in which it was done in some peripheries, they didn't find mainly TB cases. They found most pulmonary cancer, and they referred it. So what to do is, and I have just one last point to make, is to be smart and try to invest in such a way that will help the others. And don't forget the so-called orphan diseases. And the last point, that it's an entire Pandora box, but I really hope we have a chance to speak, is investing in the lowest level at the periphery communities, health worker and providers, and civil societies that can be the frontliners there, that in case for any future pandemic that it comes, you have a layer in the country, not some butterflies prepared at the global level, but people that are at the country level, at the peripheral level, ready to step up. Because you know what? We had Ebola. You go back now, we have to start from zero if Ebola comes now. There is nothing left behind. So I stop here. Thank you.
Thank you. So what I'm hearing clearly, there's a lack of will, there's a lack of awareness, perhaps lack of knowledge, a lack of enlightenment, all these all factor in why we are not tackling these diseases and raising awareness as much as we should. Konrad Reinhardt, what is your assessment? What is your evaluation? Why? The numbers speak volumes here. Why aren't we paying the attention that we need to?
In the case, it works. In the case of sepsis, people don't know what sepsis is. And there were no numbers. But there are numbers now, and they are staggering. It's according to the Global Burden of Disease report. It's 11 million per year. And it's 49 million cases. And the 6.5 million deaths from COVID-19 are deaths from sepsis, because there's something called viral sepsis, which is not known to a lot of politicians, even not a lot of infectious disease people took up the definition of sepsis, which was also put out in the WHO sepsis resolution already in 2017. So that's one issue. And when we did polls in 2003 on what lay people would know about sepsis, in most countries, less than 10% heard about it, knew what it is. And this has improved. We just did in Berlin, in Germany, a poll, and also asked the question, how many percent would know that COVID-19, the final cause of death as of most, including often TB and HIV, is sepsis. And this is not known. And only 10% after 2 years of this pandemic don't associate sepsis with COVID-19 with sepsis. And the reason for this is that things happen only in these countries if there's a lobby. And infectious disease as such has no lobby, in contrast to cancer, which is great. The cancer people in the 40s asked for a moonshot for cancer, for a Manhattan Project for cancer, rightly, and they made a difference, and there was progress. And ironically, the success that was achieved in infectious diseases in the 19th century to 1950, which resulted in a decrease of the crude death rate in the US, which was 800 per 100,000 inhabitants in 1900, to below 50 per 100,000. And this led to the notion that the book of infectious diseases could be closed. And that's why no education, etc., etc. And WHO rightly says most of the sepsis deaths are preventable by education, and we should follow along these lines. And it's the number one of cost driver in the US with 60 billion. 60 billion. Yeah, it's 11 billion at least in Germany. And this is not known to policemen, and this we need to end.
Says the founding president of the Global Sepsis Alliance, trying to enlighten people on this issue, which many, certainly I myself, did not know enough about prior to preparing for this very panel. Ricardo, you are the founder and president, aside from being an MP in Portugal, you're a founder and president of UNITE, a network of parliamentarians against infectious diseases. Policymakers, of course, play a huge role here in enlightening, educating their public. What are you doing? What is this network doing to tackle the gap in knowledge and awareness? How do you bring these issues closer to your publics?
Thanks for the question, Ali. And before answering, I'd just like to greet my colleagues. It's an honor to be with you, and particularly my colleague, Lord Herbert, has been also as previous MP and now a Lord, member of the House of Lords, really working hard, pushing the TB agenda in this political space. And I'd also like to greet Alan Donnelly and the G20, because the H20, for pushing these important topics at G20 and trying to bridge the gap here between health and finance, which I think is so critical, and it's extremely hard, as we saw just yesterday. Well, Unite was created. My background as a physician in infectious diseases was the inspiration, in a way, to create a network of members of parliament, congresses, and senates that would be engaged in global health issues, in particular infectious diseases. We are trying to fill in the gap. We have a lot of recommendations coming out of a lot of trustworthy institutions like the one we are at right now at the World Health Organizations. We have governments sitting at multilateral level. But the truth is, the ones that actually push for policy change and keep governments accountable are the true representatives of the people. And what we try to do, we don't create science. What we try to do is go from the recommendation to concrete policy change in the ground. And the truth is, what we have been hearing these last 2 days has shown us clearly that we cannot just look at infectious diseases, as we cannot just look at non-communicable diseases. And that is the reason why Unite is in September shifting towards becoming the Parliamentarians Network for Global Health, where we will, of course, put pandemic prevention, preparedness, and response as part of our agenda, but health system resilience and universal health coverage as top priorities of our work. But this leads to the issue we are debating. Why are we not as effective as we should at lowering the burden of disease, particularly these highly deadly conditions that we know about in the scientific realm? And the truth is, we don't have health systems around the world. What we have is disease reaction services. We react in the face of disease. We do not prevent. We do not have systems that are efficient at generating well-being, at generating quality of life. And this is the main problem that will lead to a continuous rise of costs and a continuous rise of the burden of disease. In Portugal, where I'm from, at the primary healthcare level, we have shown that pay-for-performance works. Speaking about cardiovascular disease, a concrete example, just the fact that we put pay-for-performance in terms of arterial hypertension led to an increase of controlled arterial hypertension among patients from 30% when there was no incentives to 80% when there were incentives. And we've seen this in diabetes and many other fields. So pay-for-performance works. The problem is the only pay-for-performance models that we have seen out there are all focused on reacting to present diseases. The question is, then how do we move forward to create incentives that actually lower the incidence of new diseases in our communities? And that leads, in just this last comment, Ali, we need to make sure that when we talk to politicians, those that actually have to make the decisions, that cost effectiveness is a useless term. What matters is affordability. What matters is budget impact this year. Saying that we're going to save money 30 years from now is pretty useless to the Minister of Health and the Minister of Finance. So trying to find mechanisms through which we can show concrete outcomes in the short political cycles, showing actually financial gains that we can achieve, and having the possibility as a scientific community, as NGOs, as patient advocates, being able to present key enhanced solutions to those that actually have to make the decisions, I think can be an important way to get both the finance and the ministers of health together.
Thank you so much, Ricardo. And your experience both as a doctor and now turned politician, I think is quite vital here, because you know both worlds in and out, and can serve as a very credible and efficient bridge here. Thank you so much. Let me go to Peter Krustrup, the professor of sport and health scientists at the University of Southern Denmark. Unfortunately, couldn't be here with us, but was kind enough to tune in virtually. Peter, the question, and you've been following this discussion, is we're trying to answer why some of the biggest killers worldwide don't receive the attention they deserve. What is your answer?
I mean, it's clear to all of us that on all continents we have huge health problems related to non-communicable diseases. And I've been working with that for 20 years, trying to find good tools to prevent and treat lifestyle diseases non-pharmacologically. And the good story is, the positive story is that we have developed evidence-based concepts that combines fun and social activities with activities that are very effective, providing broad spectrum prevention and treatment of lifestyle diseases, along with big increases in well-being and quality of life of participants. And that relates to untrained individuals across the lifespan, but also men and women with type 2 diabetes and cardiovascular diseases and prostate cancer and breast cancer. What worries me is that even though we had headlines in the CNN back in 2007 saying there's a new slogan for Weight Watchers, burn it like Beckham, that we were actually able to fight obesity, type 2 diabetes and hypertension just using modified sports. And I thought that back then in 2007, 2.1 billion people are watching the World Cup. And later on this year, we have 2.5 billion watching the World Cup. They know all about soccer. When the Women's World Cup is running in Australia and New Zealand next year, there will be 1.5 or so billion people watching it. Sport is a global language, and we have developed modified sporting activities that are easy to use, that are cheap to use, that are relevant as a broad spectrum non-pharmacological treatment of lifestyle diseases, but relatively few countries have shown interest, and relatively few politicians have shown interest in those very, very strong evidence-based concepts. So the thing is that we have tools, we have accessible and cheap tools, but they are not used to a sufficient extent. And that will be really interesting for me to discuss with you. Why is this, and how can we do something about it?
Thank you so much, Peter. Indeed, the first round, we primarily asked why. Why do these biggest killers do not receive the attention that they deserve? Why the gaps in tackling these diseases exist? I want to use this round in moving forward and asking, okay, now we've established a diagnosis. What can we do about this? Specifically, Lord Herbert, what would be your advice? How to raise that awareness, how to raise that knowledge so sufficiently and efficiently that we don't have to talk about this panel in a year or two from now?
Well, that's obviously a huge question. There are a lot of immediate things, if I think particularly about TB, which is the issue that the Global TB Caucus that I chair particularly focuses on. The first is the importance of a successful replenishment of the Global Fund, which is nearly with us. It is absolutely vital. The Global Fund has a proven track record of its interventions successfully saving lives. It has the metrics to be able to show that replenishment, further investment will continue the downward path, the downward trajectory that we need for these three diseases. So that is essential. Secondly, 3 years ago, we had a high-level meeting to try and get the fight to beat TB back on track. We all know that the SDG says that these diseases are meant to be beaten within, 7-8 years now, 2030. On the current trajectory, I'm sure Luchika will confirm it's not going to be for a century that we beat TB. The high-level meeting 3 years ago was meant to try and put that all on course, set more ambitious targets, and so on. Was very much a meeting where we came away with optimism, and of course, COVID intervened. We have the opportunity of a further high-level meeting now next year to regroup, and it will be very important that we make the argument strongly about why this disease that still kills 1.5 million or more people a year deserves attention, but also why, to do all of the things that we have discovered need to be done to prepare us for beating a future pandemic, to have the surveillance systems, to have the diagnostics, to have the ability to ramp up quickly in relation to vaccine development, to have the health systems that Ricardo was describing. All of those things will also help us to beat TB and vice versa. And that's the argument that I think we have to make. And just to say very quickly and comment in agreement with what Ricardo is saying, it's never persuasive on current finance ministers to say, spend now because you're going to save in 20 years' time. I mean, it just doesn't work for our political colleagues. And these arguments about spending to deal with future risk are very difficult to mount. And there are some sort of huge issues where we've been able to do it as a global community in relation to climate change. But look how much effort and so on that has taken. But there are arguments about a clear and present danger that can be deployed. What about drug resistance and so on? What about the next pandemic after COVID that may well be an airborne respiratory disease? This is not just about making savings and saving lives for which there is a moral and economic case over the long term. It is also about ensuring that we are never again wrong-footed in the way that we were by a pandemic that suddenly appeared 2 years ago.
Absolutely a plea for more preparedness when it comes to the next pandemic. Lukica, also the question, of course, to you, Lukica, on how we can improve. What are some of the concrete steps and examples you can give?
Yes, thank you. First of all, I like what you said, like we hopefully don't have the same panel in 2 years from now. Let me tell you, I love you, but you are very optimistic. We have these panels for the last 30 years and not too much changed. And let's be very honest, as humanity, we didn't manage to end any disease. We were dreaming about smallpox and we are, anyway, that's one. Second, I totally agree with these long time horizons, not only 10 years, but even 4 years, because how long has a Minister of Health has? As we see, you know, a year and a half, 2 years is more of an average. So indeed, presenting the case in a different way will make a difference. But you asked a very specific question to which I can give a very long answer, and I will never come back again, which I don't want to. So 3 things. We need the data. You know, everything needs to be built on the evidence. And at least coming from the TB side, and I hear from you about sepsis, people have no idea what kills their own citizens, you know? So if you are a parliamentarian or a member of the government, you need to know if TB is the biggest killer in the world and it's an airborne infection. Aren't we all scared? When you cough, can be COVID, but can be TB or whatever. But so have the data. And very few diseases had the luxury of COVID to have live data, to be able, we work with data that are 1 year old, not only in TB, in every, you know, so if you ask me now what happened last year, I'm not able to tell you till WHO will release the official data because that's how the system works, okay? Very bad. Second point is, Nick spoke about all the things, so I don't want to repeat what Nick said because then we have 6 points then from the TB world. So the second point I want to say is linked to what I said before, and sometimes is lip service, is really giving the power to the civil society and communities to drive the effort. When COVID happened and Global Fund got a lot of resources to fight COVID, one of the things that we tried to push from Stop TB, we succeeded in very few places, was to say, why don't we give money to create in like a neighborhood or in a small village, a team of people that will be prepared with basic stuff that can intervene now for COVID, but then next year they will have that basic thing. They will know who are their people, add to that whatever new thing they will have to fight. And it happened. And actually people dealing with MDR-TB, which is, by the way, killing the most among AMR causes of death, in PNG, in Papua New Guinea, were immediately shifted from MDR to COVID. But that was in one area and it took a lot of effort. Why are we not smart in investing something that we can leave behind? So that will be number 2. And on the number 3 is not in a specific order and is a lot to say, but I think at least in TB, embracing and encouraging innovations and getting the new tools, digital technologies and so on, we desperately need this. We don't have a vaccine. It is possible. We have a pipeline with 14 vaccines for TB. I'm telling this because maybe somebody tweets it. It's a shame for the world. It took us 12 years to get here. And we saw that it's possible with mRNA to get something much quicker. And in spite of that, because of lack of money and because the interest of some donors left and right, we are being told it will take maybe another 6 years to get a vaccine. Now, we need to be outraged. And in addition to pushing for R&D for TB, but maybe for the others as well, in sepsis, I think you get some new tools which are very fancy because you are in the hospitals and the big world of the north might be worried about sepsis. TB is in the big south. Nobody cares. Huh? The people that don't get the vaccine are the people that die of TB, and we don't give that much visibility. People are not scared in the big capitals about that. It's not our problem. But it's not only developing the tools, and this is my last point, is making them accessible to people. Because we can have the most amazing things, and this is for me, actually the third point is develop the new tools, but think of how you can make them accessible to everyone. Thank you very much.
No, thank you, Lucica. And passing it right on to Konrad.
Yeah, just again to get some numbers right. So sepsis as a common cause of any infection, including malaria, etc., is a major cause in the low-income countries. So more than 80%. The incidence in sub-Saharan Africa is in some countries above 3,000 per 100 inhabitants compared, and we know now about incidences, and you should know also about the incidence of tuberculosis. So we should not compete one infectious disease against the other. And the big theme here was overcoming silos and understand that things happen in our world only when policymakers have understood, as they have pretty late with COVID-19. Which is just one pandemic, just to reiterate this, as any other pandemic is as dangerous as it is, because it leads to death. And as I said, the mechanisms that lead to death is multiple organ failure. And this applies whether you have a wound infection from bacteria, or where you have influenza, or whether you have COVID or Ebola or yellow fever, etc., etc. And that the word is not understood. And we have now upcoming medications who are able to address this overshooting immune response, which are out already and come out in the Lancet within the next 2 weeks, which demonstrated that, for example, the mortality rates can be decreased by over 40% in the sickest one. And that's why one understands what the difference is between an uncomplicated infection and sepsis, which we kill ourselves, or our body kill themselves due to this overshooting immune response. And it's great that sepsis has made it now to the G7, and that the G7 ministers of health are dedicated to boost this implementation of the request of the WHO sepsis resolution. And it should get also on the agenda of the H20, because only then, and this was set out by Sir Liam Donaldson, things will only happen when sepsis comes into the political space and the public in order to things to change. And this applies for any disease, and we must not forget this.
And being on this panel here at the H20 is a good start. Clearly, the summit is shedding light on these diseases, including sepsis. Thank you, Konrad. Reinhard, Ricardo, as a doctor turned politician, certainly someone situated well to not only diagnose what is wrong, but also how to prevent it. What are some of the concrete steps moving forward?
I think we've already spoken a lot about them. Nick has mentioned the Global Fund replenishment. I think the Global Fund is a great example. I'm going to start global and then go local, because they show a very powerful tool to get government money and private money moving in the same direction, using mechanisms that incentivize both sides, having concrete metrics, having very good financial tools creating trust between all of the different partners. These are the kind of tools that the World Bank should be using, the IMF should be using. And that means that we also need to reshape the way we look at healthcare at large. One of the main problems, in my opinion, is that in many countries, when you talk about with politicians, healthcare is seen almost as a charitable part of policy. It's the social part, sitting in the back of the room. We need health to be seen as the core for development and economic growth. That is the major shift that is not happening. And to do that, possibly we need to change the way we measure growth and economic development, which means that, and just yesterday I was talking with Professor Rifat Atun about how we need to rethink even GDP as a metric for growth, to look at other indexes that look at health and well-being as the main driver for economic growth. So these are major changes that the G20, as a recommendation, I think can play a pivotal role. They are the ones that at the World Bank can change the way we measure economic development, and to make sure that health and well-being brings together the economics, the social, and the health politics in one realm. In terms of the local side, I know you're tight on time, but just to say, going down, then drilling down on the specific diseases and what we do at the national level. I'll give a concrete case study from my university where we, facing all of these challenges, how do we address and convince policymakers to move in a certain direction? And so we've used gamification. Using data, we've created apps where you can see the policies being implemented in a specific field. We've done it in hepatitis C, we're doing it now in flu, and which you can see how each country is doing in terms of the policies being implemented, and it calculates the health outcomes based on those policies. And then within the app, each of us can play Minister of Health and change the policies and calculate the health outcomes. Why is this important? Because it provides data in a way that anyone, from a journalist to a patient advocate to a politician, can understand. And everyone understands the cost opportunity that is there, which is something we don't talk about. When it comes to politics, it's not just what we're going to achieve with an investment. The most important discussion is what is not going to happen due to your inaction as minister, as prime minister, as president. And to have data that shows what we are not achieving due to inaction is critical to get public support. So I would end by saying that we discuss a lot about health for all and universal health coverage. Universal health coverage is only possible if we have patients on board. And the patient voice is not present at all still. And so we need health by the people, we need health with the people, we need health for the people. If we do that, we can achieve health for all to become not just an utopia, which it is today, but to become a reality. Thank you.
Thank you so much, Ricardo, for this very passionate plea to put patients first and put health in general as a subject matter, push it back, bring it back from the back to the forefront, and give it the forum and importance that it deserves. Peter, to wrap up the session, I also want to bring you in one more time, of course, and get your final thoughts and recommendations.
Thanks a lot. I agree with the panel that, data is really important and knowledge. But in terms of most non-communicable diseases, we already know the data and the incidence, and we have knowledge about how to do something about it. What we are basically lacking in terms of fighting the biggest killer in the world is action. And we need action because we got the data and we got the knowledge, and we need to prioritize this. And yes, I agree, we need to avoid silos. We need the stakeholders at the municipality and governmental level to work together. And we need, for example, the sporting clubs to contribute to the health of nations and the health of the world. And we have concepts. One interesting example among many examples of what physical activity can do is the concept that we have developed called Football for the Heart. With just 3 to 6 months of training, providing broad spectrum health effects on the cardiovascular side, we can bring down hypertension by 10 millimeters of mercury. We can increase the VO2 max by 4 milliliters per minute per kilogram, corresponding to a decrease in the risk of cardiovascular disease of 50%. And it's easy. It's just a matter of using the concepts, providing the actions, making a collaboration between the medical doctors and the political stakeholders and the movement of sports, which is so big. As I started out, everybody knows about sports, and we are actually providing some concepts where sporting clubs and also sporting activities at the municipality level can do so much to cause very cheap solutions and broad spectrum prevention, and at the same time have the general population participating in healthy activities that are not boring, that can ensure adherence and that are fun and social. And that brings all the good things about focusing on health together, because health is, I agree fully, a matter of the physical health, the fitness, but also well-being and quality of life.
It's very clear, judging by this conversation, that still a lot needs to be done here to shift the focus. But if I may say, if your dedication and passion of all the speakers here is any indication, I'm not that pessimistic. If these are the people at the forefront trying to break down the barriers and bring about the awareness and attention to the diseases, then I can only say as a moderator, we are in good hands, and there might be some cause for optimism. Thank you so much indeed. Before I hand over now to the next panel, which by the way, we're just a lead-in, if you will, to the next panel, which is titled, Why is Cardiovascular Disease the #1 killer worldwide despite being preventable? That is going to be chaired by Professor Rifat Atum from Harvard University. But please, everyone, join me in thanking this outstanding panel. Thank you so much.
Okay, so welcome back. We've had a really wonderful session in a really outstanding panel. But we have another outstanding panel. We're now going to focus on why cardiovascular disease is the #1 killer worldwide, despite being preventable. And we're starting 10 minutes late, and I want to ask Alan his permission verbally.
Yes, what we're going to do is eat into the coffee break. So if you want a coffee, it's outside, just grab one and bring it back in. But I think we're just going to scrap the coffee break and finish a bit earlier, hopefully. So everyone agrees. Everyone agrees.
Good, so I'll use 10 minutes so we have the full hour, because we really have an outstanding panel, starting with a keynote from Bente Mikkelsen, who's the director of NCD department at WHO. Then we'll have a panel discussion with Thea Collins. Thea is a long-lasting friend and the lead of the global NCD platform in the office of the Deputy Director General at the World Health Organization. Then my friend and colleague, Professor Kaushik Ray, who is a professor of public health at Imperial College London. And Kosh, as he's affectionately known, recently led the World Health Federation Cholesterol Roadmap. He was the chair of this group, and he acts as the president of the European Atherosclerosis Society. Then we have Hasib Ahmed, and
and we should first congratulate him. He's just been appointed as the president of Novartis Europe. So congratulations, Hasib. And then Matthias Egermark, who's senior vice president for cardiometabolic disease area network for Roche Diagnostics. And last but not least, we have Professor Hasbullah Tabrani, who's going to provide us with some concluding remarks. So I'm not going to say much regarding the burden or the economic cost, but maybe just because this will be picked up by my other colleagues, but I heard some of the numbers from the earlier discussion. Now, cardiovascular disease is #1 killer, and many of these deaths can be prevented. The health costs are huge. We'll hear this from the panel. Economic costs are massive. Just in the US, the direct cost, this is cost to the health system each year is around $244 billion. To the European Union, $111 billion. Direct plus indirect cost, the economic cost in the US is around $400 billion a year, around 15% of what the US spends on healthcare each year. And in Japan, around 110 billion. But very few countries have reliable data on cost. This is something we'll discuss because this is #1 killer and we really don't know what's happening. This is unacceptable. But I cannot think of a better person than to start the discussions with Bente Mikkelsen, who's really passionate and has been leading not just cardiovascular disease, but the NCD work at WHO. Bente, over to you.
Thank you very much and good afternoon. I'm extremely honored to be here and I want to congratulate all of you for picking non-communicable diseases as your focus. And it's rightly so. And you probably know, all of you, that non-communicable diseases, cardiovascular diseases, diabetes, cancer, chronic respiratory diseases, and its risk factors represent 74% of all global deaths. Unfortunately, as you are saying, Rifat, we live still in the Millennium Development Goal area when it comes to funding, and I'm sure you will come back to that. So all the institutions that are set up globally for international funding is still not including NCD to the full. So that is one of the things I hope you will focus on at least. So it is the biggest killer, and you will focus later today on #1, which actually kills 32% of all people, cardiovascular diseases. And I will definitely second your choice on this, because what we have recently seen when we launched for the first time in 21 years, and it's absolutely necessary, and a protocol-based treatment for hypertension. What we saw then was that less than 50% of people living with hypertension knows it. And of those, only 40% are on treatment and 20% under control. And we are talking about innovation. We are talking about bone being agile. How can that be? It's one of the absolutely oldest diseases. But what probably is not that known, and that's why we also launched the Global Diabetes Compact on the 100 years of discovery of insulin, is that still 100 years after the discovery of insulin, only 50% of those in need have it on a regular basis. And this is also a life-saving commodity for those with type 1 diabetes. So I could go on, but I think what you need to know from me is that in addition to be very happy, I need to be sure that you know that we need you, and the member states of WHO has just decided on an implementation roadmap. They have supported targets for diabetes. They are very happy that we have a global breast cancer initiative, childhood cancer initiative, cervical cancer elimination initiative, and that we focus on health systems to respond. We cannot do this alone. So what is happening now and really have picked up in the 2 last years is our regular dialogue with private sector. So I'm extremely happy to see that on the asks asked by WHO, we now get commitments. And again, I just want to, for inspiration, to give you one example. We now see that we will have pre-qualification or maybe as many as 4 insulins and even including biosimilars. We see an interest from device industry to also pre-qualify devices. And we see that we have several donors, Swiss Development Agency, Norwegian government, Denmark government, that really see the importance. I will end up with one thing. I'm sure you have touched on COVID. And it's horrible to say, but COVID was really an eye-opener when it comes to NCD. I think everybody know that there cannot be any health security, any preparedness without focusing on non-communicable diseases. And there is still a lot of money flowing in that direction. Please help us. So this is also benefiting NCD. I'm sure you have some questions, but I'm very happy to have these few moments with you. Thank you.
Thank you. And Bente is going to go to another meeting in about 10 minutes. So I'm going to use the chair's privileges and ask her the questions before I invite the panelists to make their interventions. So Bente, let me just follow. You mentioned, I noted financing here in capital letters and bold. Cardiovascular is such a big problem, yet when we look at the amount of financing that is channeled to cardiovascular disease, it's minuscule. Why is that?
So it's for cardiovascular, but it's NCD in general. So as I said, one of the reasons is that the financial international instruments is not still including NCD. But of course, it's also that we see that we haven't got a priority as needed for inclusion in UHC. And domestic funding is and has to be number one. So I think even, and I just listened to the Regional Committee of Afro, every government mentioned NCD because of course they are the one that really see the epidemiological changes now in front of their eyes. But from having this awareness to really change their budget priorities is, of course, as we all know, very difficult. So I think we need to help. We need to help by, and it's very, very sort of practical help. All of us need to help those who are making the proposals for the financial institutions to also include NCD. We need to live the best buys, namely to raise taxations on tobacco, alcohol, sugar-sweetened beverages, and to increase revenue to governments that way. And we need also to look into other financial instruments, as we discussed last time I discussed with you in our NCD and financing meeting in Denmark.
Yes. And thank you. And before you leave the meeting, I want to go back to the meeting which you organized in Copenhagen, in Denmark, that focused on financing and innovative financing of NCDs. And it was very interesting that yesterday we had a really wonderful day, and some of the speakers and panelists did actually mention the meeting and some of the discussions and even the papers, which was really quite amazing. One of my papers, I was really amazed on this. And what we also heard was something very interesting in relation to the green bonds, which increased from 3 billion to 3 trillion just in the space of 10 years, I believe. I'm probably wrong quoting that time, but in a short space of time. So really to move the needle, again, we mustn't rob Paul to pay Peter or rob Peter to pay Paul, because I'm also involved in TB and cancer, and I'm really passionate about access and equity. So how can we move the needle, not just a little bit, but actually massively?
So I think it's not difficult actually, because when we recently did our global investment case, we see that with less than $1, we can save 7 million lives. We have a high return of investment. So we are battling a little bit with several misconceptions that it's complicated, it's expensive, it's almost like impossible. What I think is important to see is the places where we're able to make things at scale. And actually, hypertension is one of the best examples. And we can showcase this, and we will attract in people that want to invest in global health. So I think there is no easy way, but I think everybody is now geared towards solidarity, try to sort of make the world more safe and secure and be prepared. And what is then better to invest in NCD, I would say.
Absolutely. What better place to invest in? But when I was at the Global Fund, We used to say, the impossible we manage, miracles take time. But I think that's the kind of passion we need to have for NCDs and cardiovascular disease. But please join me in thanking Bente for joining us and for her time. Thank you. And what a great segue to our panelists on a very high bar indeed. So I'm going to start with Thea Collins for her intervention.
Thank you, Rifat, and thank you to Alan and all the organizers for the summit. It's really a pleasure to be here. I just want to register that I guess I'm more of in the role of an expert. I would hesitate to just speak on behalf of whole WHO. So just to start with a disclaimer. I would like to, because the question really is from the very beginning, as our chair posed this, why is cardiovascular disease #1 killer in the world, and particularly in G20 countries, the countries that we refer as G20, and obviously we expect that they will have a better epidemiological profile. I would just, I think that it would be really helpful for our panel, from my perspective, to understand where we're coming from and what is it that we are really trying to achieve, and why are we concerned about mortality. From the Sustainable Development Goals framework and from the WHO perspective, I will have to say that it's not the overall mortality that concerns us so much, but it's the premature or amenable mortality. And particularly in these countries, as the Harvard OECD report demonstrated, that was really shocking that there are number of deaths, they're very high, 18.5 million deaths, and amenable mortality is particularly high when, and WHO defines it as deaths under age 69, but it's not only the age issue. We are also concerned about issues that we have in these countries, that's inequalities. And I think the United States was a good example. And so I would just suggest that once we start discussing different issues and referring to G20 countries, also understand that this group of countries are not necessarily the most prosperous and healthiest nations on earth, but these are really diverse group of countries. They encompass all the regions of the World Health Organization. And also they have very different socio-cultural and political contexts. And so once we start discussing several issues and also understanding the organization of healthcare systems in these countries, we just keep in mind the diversity of this group.
Excellent, and really excellent segue to the Professor Hasbullah Tabrani's concluding remarks later on. He's extremely distinguished individual as the former Dean of the School of Public Health in University of Indonesia and currently the lead co-chair of the T20 Global Health Security and COVID-19 Task Force. And we will ask him at the end, when he's concluding, to also tell us what concretely G20 could do. But let me move on to Professor Kaushik Ray. Kaush, over to you.
Thanks, Rifat. So we've heard about this. I've really enjoyed the last couple of days, and I've learned a lot. I've been thinking about this in a bit more detail. And we need to think about the destination is to reduce those 18 million deaths. That's where we want to get to. But to do that, we need to understand the journey in particular. And there's a lot of things that we can learn from COVID. When we first had COVID, we didn't go and vaccinate the people going into the hospitals. You basically addressed the immediate problem. We needed more ICU beds. We needed more beds in hospitals, but the conveyor belts of people were going to come in. So you basically focused on vaccination, rollout, all of the things that we've heard. So we understand the journey that results in all of those deaths. And that is very simple. It's lifelong exposure to cholesterol in the blood vessel wall and its consequences. So what you've seen with COVID, with the hospital admissions and then the vaccination and that prevention in a short window, stretch that out throughout that life course. Now, knowing that basically means that we can provide pragmatic, scalable solutions. It's not one size fits all, but we can do that different things at different stages of the life course. So importantly, for example, in the WHF cholesterol roadmap, there are a number of actionable points. First, improve awareness. And that basically means framing it. There are so many people that separate cholesterol and cholesterol exposure, and they think it's only due to high cholesterol levels. The vast majority that will develop these conditions and heart attacks and strokes will not have high levels of cholesterol, but it will be too high for them because that's what their blood vessel wall sees. Rollout, prevention throughout the life course. We need to reinforce certain things. We need to think about screening. We need to think about assessment later on in life. 1 in 311 individuals in the world is born with a condition called familial hypercholesterolemia, resulting in lifelong elevations. If you don't look, you can't find that. Elevated lipoprotein little a. So if you don't look, you can't find that. Implementation. We need to implement system-wide approaches at scale, top-down and bottom-up. Top-down meaning we have to make decisions at policy level. But when we talk about population health, how are you going to get to the population? The basic unit of interaction in healthcare is the doctor and the patient. Both parties have to play a part. So part of the solutions have to be around helping both parties come together to agree on what is the right thing for them to do. Establish surveillance, establish data generation, because that is what will drive both the arguments around fiscal costs, the benefits, and knowing what we're doing is actually good enough. So I would put to the panel, who's going to do all of this? How are we going to get together to solve these problems? Thank you.
Thank you, Kosh. And that's a really excellent question, which being a good chair, I'm going to ask you when we come to the round of questions, so you might have some time to think about it. But it's an excellent question, who's going to do it? We heard yesterday that we have everyone in this room who can we have the solutions and we have the will here. So think about who's going to do it for cardiovascular disease. So let me move on to Hasib. Hasib, over to you.
Great, thank you, Rifat. So, maybe I start from a slightly different perspective. I think at a time when the world's looking for economic growth, I think it's a true statement to say it's tough to be a healthy economy when your population has poor health, poor access to health. Over the last 2.5 years, it's been well documented, particularly in the last fireside discussion, we've seen the direct correlation between health and wealth. We've seen that the health of our nations is intrinsically linked to both economic growth and the security of societies. And COVID put substantial pressure on our healthcare systems, particularly for those patients with chronic disease. And as a result, many of those patients living with the disease haven't been receiving proper diagnosis, access to healthcare professionals, treatments, other interventions, and effectively have been warehoused to some extent over these last 2.5 years. When we think of the biggest healthcare challenges of the day, it's remarkable that cardiovascular disease accounts for, every year, more deaths than any other condition, any other non-communicable disease put together. In fact, per year accounts for more deaths than COVID has done in the last 2.5 years. So for a condition that impacts and causes 18 million deaths per year and affects 300 million people worldwide, it is likely that cardiovascular disease will be the largest and most significant healthcare crisis over the next 20 or so years. Probably one of the most damning and acute things is that if you look in the last 5 to 7 years, if you look at the statistics since 2050, and they really are quite alarming, that the mortality gains that we had seen previously in cardiovascular disease have now started to flatten, and we need, as a collective, to bend the curve of life. The good news is that 80% of cardiovascular disease and cardiovascular deaths are preventable. So 80% of deaths are preventable, and we do know how to prevent them. But to achieve this is going to have to be a really bold transformation in how we think and transform how care is delivered, and most importantly, how we work together. So rather than working in silos or potentially even adversarial, how can we raise our heads and look at this from a system perspective, look at it more holistically and more strategically? There's no government, healthcare system, payer, provider organization, or private industry organization that's going to be able to solve this alone. It's really going to require strategic public-private partnerships. And we've seen that when strategic public-private partnerships work, and COVID has been the best example of that, they can achieve amazing things when you put people around the same table to achieve the same goal and to work together towards a common enemy, if you like, which is the disease itself. And it's with that, I'm delighted to be here as part of this panel discussion.
No, thank you, Hasi, for your really excellent intervention. Some very important takeaways, the inextricable linkage between health, economy, and security and well-being of our societies. And we talked about emerging health threats and the period between the pandemics was shortening. But actually, we have an emerging and growing health threat that's going to, like a tsunami, that's going to hit us with cardiovascular disease. And the improvements are flattening, as you've alluded to in your presentation. So we need a bold transformation through the strategic PPPs, the strategic public-private partnerships. So Matthias, over to you.
Thank you. Yes, we definitely have a big threat ahead of us, but also a great opportunity to tackle it. As we're seeing the COVID pandemic at least waning, still there, but waning, it's now time to take new action against an even bigger killer, the cardiovascular diseases. And it really warms my heart that the H20 forum has made this a priority, that it's on the agenda. Thank you. And the warmth of that feeling comes from a very personal experience, having worked in clinical practice in primary care, where most of these patients are seen and should be seen. And because the pure amount, how many of our fellow humans out there who have cardiovascular disease, you see it in primary care, and how difficult it is to manage that breathlessness, this chest discomfort. Is it a common cold or is it a heart condition that can suddenly worsen? That patient with chronic heart failure, can I safely send her home? So in these situations, we need high quality diagnostics to make the right choices and both prevent and intervene. And that's what ultimately brought me to this role in Roche Diagnostics, a company that's brought high quality tests to the market that enables earlier detection and prevention for better outcomes as well as more sustainable healthcare systems. And I'm delighted that we're talking about how we can bring together technology with policy to tackle the cardiovascular pandemic. And our action is really needed now as we see how the previous improvements in cardiovascular mortality have flattened in the rich world and even seem to increasing in some parts, and clearly is surging in the developing world where 2/3 to 75% of all cases are occurring. So we need to broaden our approach to the cardiovascular care, I think, and from the previous extensive focus on acute management and also the policy priority on healthy lifestyles for the general population, to also consider much more the patients who already have risk factors, already have cardiovascular disease, and manage the gaps there, address the gaps there, which are, for example, delay in diagnosis. 80% of heart failure patients are discovered only in the emergency room, even though this condition develops over time. And 50% or 47%, according to Lancet Commission Diagnostics, of the world's population don't even have access to good diagnostics. There's also lack of use of preventive medicines. There's discontinuity in the chain of care from the home to doctor's office to hospital and back. There are disparities between genders, socioeconomic groups, and ethnicities in terms of their access to care and their outcomes. So to tackle all this, we need earlier detection, better diagnosis, a better follow-up and continuity of care. And the solution will have many components. And one of them will have to be in vitro diagnostics. The testing that takes up about 1 or 2% of healthcare budgets around the world, but actually drives 60 to 70% of all decisions, of all clinical decisions, making it one of the biggest levers we have to improve healthcare and make it more sustainable and effective. So we saw this very clearly during the COVID pandemic. So I'm now really looking forward to discuss how we can come together across sectors to take these learnings and use them in addressing the cardiovascular pandemic. Thank you.
Yeah, thank you, Matthias. Really excellent intervention, a perfect segue to the questions. But I just wanted to, when you start with an optimistic voice, And there are many opportunities, which is great because we often talk about problems. And you also brought a human face to this. These are not just numbers, these are individuals and their families. And you mentioned that we've got high quality diagnostics, but no access, huge disparities. We need earlier detection, but also management across the care continuum, but it's lifelong. This is not just a one-off intervention, but we need a multi-sectoral response. So, having made such an excellent presentation, you deserve the first question. So how is it that a preventable disease in today's age, we're in the 21st century, going to Mars and all these places, that this is the #1 killer globally when there's highly cost-effective interventions to detect, prevent, and treat with innovative medications that are coming through the pipeline?
Well, I think healthcare systems have traditionally been, just by the pure nature of the condition, been forced to focus on the acute condition. We need to manage the emergencies in cardiovascular disease, and that has led to a strong investment in building the infrastructure to manage the acute complications. But what has been neglected in all this, I think, is the follow-up, the secondary prevention after hospitalization. We see rehospitalization rates of 25-30% for heart failure patients that are discharged from hospital. There is a lack of continuity. There is a lack of secondary prevention there. And as I alluded to briefly before, there are also big disparities in access to care between genders, between socioeconomic groups and ethnic groups. For example, women have, although the incidence of cardiovascular diseases in some indications at least slightly lower among women, they have worse prognosis and higher mortality rates after intervention. So there are clearly gaps in how we address specific groups that are also driving bad outcomes overall. And behind all this is this issue of lack of access to early detection and diagnosis. So we need to address the preventable complications of cardiovascular disease. So both primary, we need to add to the primary prevention also the secondary prevention aspect. And there is, and to the point about from the fireside chat, that we need to do both the long-term prevention, but also do initiatives that can improve the standing now. So what can be done now with short-term effects is really to improve the follow-up, the handover from secondary care to primary care, better communication between primary and secondary care, and better handovers, to reduce readmission rates, lack of follow-up, which can have short-term effects, but also to make sure we really invest in building the diagnostic infrastructure. There was a calculation I saw from the University of Sheffield recently that estimated that if we would be able to diagnose all patients with cardiovascular disease or risk factors for cardiovascular disease in England, and then treat them according to current standard praxis, that would avoid the 3.4 million cases of cardiovascular disease in the next 25 years, just in England, and save up to 68 million pounds. So there are clearly gains to be had by increasing diagnosis early in order to enable better prevention.
Yes. So thank you. So there are many solutions, but systems are designed to manage acute complications. As we heard from Ricardo later, and Ricardo said we don't really have health systems, but actually disease systems that manage fragments of episodes. So we need to focus on prevention, primary as well as, very importantly, secondary prevention, but also focus on specific groups. And the potential is huge. So I'm going to ask Sib, given this potential and opportunities, what are the key challenges that policymakers and patients face when finding tangible solutions to this massive problem? And could you provide some concrete examples from your work and involvement in different countries?
Yeah, there's two things that really jump to mind when you ask me the question around what are the challenges for policymakers and patients. And the two things that come to mind is awareness or consciousness that this is a problem. and the second is around cohesive leadership. And maybe if I just delve into those, in terms of consciousness or awareness, there isn't one person amongst the lay public that isn't aware of cardiovascular disease and either hasn't been affected by it directly or has someone within their family circle that's been affected. But if you ask them, how many of you think about cardiovascular disease on a day-to-day basis? It's very, very low. It's minimal. When I think of leadership, and within my organization, I have the opportunity and the privilege to work with colleagues across the ecosystem in the two largest causes of death, cardiovascular disease and oncology. When I look at the cancer space and how well coordinated clinical leadership, patient advocacy, academia, private sector is, it is something to admire. How the oncology community has got together to solve some of the biggest challenges, not just by putting in place a moonshot, but then by working together. It's something really impressive. I actually just yesterday asked someone in my team at work to go onto Google Analytics and see what is the difference in searches between people who search for CVD policy versus cancer or oncology policy. You get a sense of people working in the space. And over the last year, month on month, you're seeing a 7 to 10-fold delta between the two, which shows there's a community of people out there who actively are more conscious and aware that oncology and cancer care is a problem. And they're searching for it because they're involved. And these are people who are obviously quite intimately involved in the disease area. And so I think they're the biggest challenges in terms of concrete examples, both when it comes to cancer care and when it comes to cardiovascular disease. We are partnering quite intensively with governments for example, in Hungary, in the United Arab Emirates, both the oncology and the cancer care space. In cardiovascular disease, we signed a significant partnership with the NHS in England. And this is something that we believe is really important. And this is not just a bilateral agreement. This is about different parties coming to the table to really address this in a much more systematic and holistic way.
So this is sort of novel strategic public-private partnerships. Could you elaborate on what's different about these examples?
Between the specific examples that I
just gave? For example, the example with the NHS or you.
Yeah, so maybe I'll give the example in Hungary, for example. And this is an interesting one because typically, as a company and even the clinical community, normally we would, if we think of government stakeholders, we think of the Department of Health. But when we started engaging in discussions with government, firstly with the Cabinet Office around cardiovascular disease, there was a lot of interest actually from the Ministry of Innovation, where they really want to say, well, how can we use digital and data infrastructure, emerging electronic health record system that they're developing, and how can you use technology and innovation to better risk stratify populations, to create a more pervasive management of cardiovascular disease. And a lot of our partnership is actually with the Ministry of Innovation, rather than what we typically do, which is working with, a health ministry or with the clinical community. And they then become the coordinators who then bring in, obviously, the clinical community. So that's what we're doing in Hungary. In the NHS in England, the partnership is on population health for secondary prevention. The NHS already had a secondary prevention disease pathway. So we are working with them in partnership to really treat secondary prevention and bring clinical communities, people like Kosh and other leaders within the system to say, how can we better risk stratify populations, engage them, bring them into the care pathway, and ensure that clinicians at the front line in primary care, as well as secondary care, have access to all the right information and all the relevant interventions when needed.
Excellent example. So transitioning from sort of this episodic and reactive management of acute insults and events to managing the care pathway, but very importantly, beyond individual, just moving to population level, but stratification to address specific risk groups. This is very encouraging, and hopefully this will help move needle. And we need to have more examples of these. So I'm going to go to Thea and Kosh, because both of them mentioned data, the importance of the, or rather the lack of it in some settings. And how is it that G20 G20 countries that are some of the most sophisticated countries in the world, have very little comparable data in relation to cardiovascular disease, which is the #1 killer in these countries. And what can we do to ensure that we have these data?
I wish I had a 1-minute answer to that question.
I wish you might.
But I can just, maybe I will try to break this down data, because this is something that everybody's afraid of talking. And what is this data really? And then we need more data. Sometimes we have too much data, and what to do with this data. If we refer to G20 countries, I can assure you that they have tons of data. But it's just, as you correctly mentioned, is it comparable? Because methodologically, we don't have comparable data, because every country is different. Their surveillance systems are different. Their disease burden is different. So there we already have one barrier. When we do have sometimes a lot of information, but we don't know what to do with that. From WHO perspective, we work with ministries of health. We definitely don't suffer from the shortage of data. We have whole global observatories working on that. But we do also acknowledge that we rely on governments. So we rely on data that countries report to us, and we know that there are shortcomings. Once you go to country and report, you worked particularly in that Eastern European bloc and know perfectly well, facility data. Governments rely on facility data, and facility data sometimes collected really haphazardly. Sometimes somebody just scribbles something on paper, and this is all you got, and then it has to be systematized. So just to perhaps to just step back and to make some sense of this mess, is that we need to understand what the goal is. And at this point, it seems that at least from the UN perspective, and from all countries, rich and poor, and from all partners' perspective, we are aligning with the SDGs, and we are trying to achieve SDG target 3.4, which is 1/3 reduction in mortality from all non-communicable diseases, all major group diseases. And cardiovascular disease happens to be the biggest contributor. So if we address CVD, then we can reasonably say that we will be closer. A lot of countries will be closer to this 1/3 reduction target. That said, that implies that we need more epidemiological surveillance and more data on risk factors and morbidity, mortality, cancer registries. Cardiovascular diseases are also a whole group of diseases. Obviously, every country has different one that is dominant, and they need to prioritize. But we also need cost data. And I think this report that referred to, and I hope that it will be widely available, this on G20, particularly focusing on cardiovascular disease, it has special sections that refer to cost. And it's very interesting, because cost also means different things to different people. And then sometimes we say budgeting, sometimes we say financing, sometimes economic cost, this cost. But we need to be also clear, there are many types of costs, and particularly we're talking in this case, Rifat mentioned about economic cost, which includes direct, indirect costs, and plus foregone opportunities. And this is very difficult, because that also includes the lost productivity, and that goes back to the situation when we have young people dying early. And this is a big problem. So we do need epidemiological, demographic, cost data, and then broken it down in a way that is comparable, so countries can come together and conduct some comparative analysis. And then we are already speaking, then we understand how we are reaching the targets, or maybe we're not. So just to cut it short, I think the cost, speaking of cost, it also cuts to investments. And I think most countries, even if they have a huge GDP, and even if they spend a lot in other sectors, healthcare spending is always low. Okay, we can say that United States spends more per capita than any other country, but then we need to break down that cost too and see where the money is going. And then whether it's really addressing the needs, and the colleagues were speaking about primary prevention and secondary prevention. And then we don't want to spend all this money on emergency care when there are heart attacks and stroke, and when it's too late. And it's also interesting, and there's one sentence in that report that I reread several times, and it says that the biggest driver of cost in CVD, or CVD really in the United States, is rehabilitative care for stroke. And so this is a good thing that for rehabilitation, but it would have been even better if we hadn't had the stroke. So I think we need to, when we talk about data, we need to think clearly, what is it that we're looking for? What kind of information, and where we need to invest as a country, as a government? And also just another piece I would like to add, because I see that there are a lot of colleagues from the pharmaceutical industry in particular, and it's also interesting that 78% of big pharma companies are in G20 countries. Switzerland has 13%, but Switzerland is not part of G20. But if we put all this together, and we also know the COVID also showed us that pharmaceutical companies actually do collect data, and they have a lot of data. But sometimes governments either shy away, or they don't have a mechanism of asking for this data or reviewing this data. So speaking of partnerships, I think there are a lot of sectors and stakeholders who have the data, but they sometimes don't even know how to, where to deliver this and how this can be analyzed. So the policies get actually influenced. So this links that, from data to policy, from policy to program to country. This is where we've been here for decades. These are the linkages that we're missing. We kind of know the barriers, but we are having a hard time making these links. And G20, again, I want to stress that in G20, we have India, we have China, and we have United States, totally different countries. And it's actually the G20 plus, and G20 plus includes the European Union. And there we have a whole range of countries with totally different values, actually. And healthcare system is one of the major societal determinants and a value-driven area. So saying that all health systems can just do the same thing and let's just look at the WHO building blocks, it doesn't work. So that's why we're here, and that's why we need partnerships, and that's why we need to keep talking to everyone who is in the health sphere and beyond, so we can really get somewhere.
Excellent. There was a real tour de force of what kind of data we need, why, and why now. And one takeaway message is too little, too late means too costly, clearly. And you posed the question regarding the private sector. So I'm going to ask both Matthias and Hasib before, after Kosh's intervention. So Kosh, again, if you could comment on the data issue, but also bringing back your question back to you. Who's going to do all of this?
So I guess I would basically say it would be an ask to the G20 to really provide the mandate to perhaps set the right strategy and direction and how we can accelerate action globally, perhaps through a task force to bring, the stakeholders. I've seen multiple key stakeholders in this room. They're all providing solutions. And we need to start thinking about some of these things as solutions and how we put them together. Now, to your question about data, I completely agree with everything that you've just said. But the question I would also put to you is the data has to be not just interpreted, it has to be presented in the way that is then actionable so that you change. Collecting data year on year and not patting ourselves on the back, but wearing these numbers is a badge of shame. It's not a badge of honor to show the same numbers again and again and again after a decade. So what are you going to do about it? So let me give you you asked for a couple of examples maybe. So again, through a couple of academic private partnerships and studies that I've been involved with, the aims were to do some of these data collection and surveys, fine. And we would have generated exactly the same amount of, or the same answer as the previous 5 surveys, but we changed the narrative when we did the analyses. Because what it basically pointed out is that you mentioned what we should be doing in control. What we said is, if you do it down this approach, it is not going to work. It's mathematically impossible. And this was related to secondary prevention and, for example, cholesterol lowering. And it said, even if you use the first drugs, only 20% will ever get to target. So basically, simple message, Europe, where this was done, uses monotherapy. We don't use combination therapy. And you can point to our colleagues in hypertension. They realized this 10 years ago. You've got to start with combination therapy. And this week at the ESC meeting that I came back from, that message, we need to start with combination therapy. The more steps you have, the more inertia you get. So the projects of then, now that are emerging, is around how we implement combination therapies and what's left to try and reduce those steps. So that's again data generation, but then to give you something to aim for. And then you're focusing on how to implement that. And the other part of these data is, remember, coming back to NCDs, all of these things, diabetes, what do you die from? Cardiovascular disease. When you have hypertension, what are you dying from? Heart attacks and strokes. That's that furring up of the blood vessels. So with all of these things, the N is the problem part, because our citizens, our patients, they feel fine. They don't feel any better or worse. So the flip side of our imaginary friend risk is benefit. So we've got to basically help our patients and our doctors better understand the benefits of what we are suggesting. And then they might actually be more invested. They might want to maintain this lifelong. Because fortunately, one of the things we do know is nature really doesn't care how you lower blood pressure, how you lower cholesterol. As long as you do it early enough and for long enough for your level of risk. It's really very simple. So we can focus on solutions, pragmatic, scalable solutions.
Excellent. Thank you, Kosh. So more nuanced approaches to interventions, so not just monotherapies, but combination therapies. But you said something very important. We tend to focus a lot around the supply side interventions. But what we've learned from COVID-19 is that behavior is so important, and this came up in the discussions earlier today. So focusing more on what we call in sort of health policy jargon, on the demand side, engaging individuals, populations in the care, especially important for a condition that is lifelong, where the interventions are going to be lifelong. And who's going to do it? I'm going to come back to this question to expand on it, but because Tia said WHO is working, she's working with countries to try and achieve the SDG 3.4 target to address the cardiovascular disease and reduce the burden of death. Quite an ambitious agenda. So what's private sector going to do? How are you going to contribute to this important agenda? Sorry to put you on the spot, Hasib and Matthias.
No, oh my God. So I mean, I think it's starting now just by engaging in this debate. I mean, if we're going to be more proactive about tackling this silent pandemic, I think it's great that we have this H20 summit and this topic is being discussed. But I think the answer for us is to do it at scale. I mean, so Kosh mentioned scale. For us to be more proactive in tackling this pandemic and for industry to get involved, it's about doing this at pace and at scale. I guess, you know, within that, what we see in this area, and I think it's on both sides, it's on the academic side and on the industry side. Might be a bit provocative to say this, but there are probably more pilots when it comes to population health type initiatives in cardiovascular disease than there is in the entire global airline industry. I mean, there's a plethora of pilots, everyone wants to pilot it. We know the solutions. Many private sector organizations have technical solutions that can help across the pathway. We also have skills within our own organizations. We have access to data. And I think we break down the barriers from this kind of provider and purchaser relationship. We can actually work together and do this at real pace and scale.
Excellent. So the operative word is scale and get rid of pilots. I couldn't agree more. Very important. So private sector is an important contribution. Matthias.
Yes, thank you. No, fully agreed. I was actually about to say the same thing and refer to the concept of pilotitis, pathological proliferation of pilots.
Also a chronic disease.
Yes, indeed. But I see this happening already, and not least in the in vitro diagnostic space, where traditionally the focus has been on developing high quality tests and installing the instruments, ensuring that we have a huge installed capacity base in hospitals where instruments can analyze blood samples and churn out results. But increasingly, if we want to add value to healthcare, we need to make sure that the healthcare system can also use those results more efficiently. So I see in local examples in Europe, for example, in countries like Finland and Spain, we have worked with hospitals to help implement changes in the pathway of patients, where patients are referred to from hospital to primary care based on their levels of a natriuretic peptide, for example, in order to optimize their patient journey. And that high level of engagement, where it's not only about installing technology, but actually working together to improve the pathway, the patient journey. That's what I think would be the future of public-private collaboration.
Excellent. So as Kors said, working together with citizens, with populations and patients, not operational level as well as at the macro level, as Hasib was saying. So I'm going to ask each of you for a 30-second short, sharp intervention. What will your recommendation be to the G20 meeting? Because Professor Hasbullah Thabrani will be leading the T20 summit next week in Bali. So who'd like to start? The concrete recommendations. So starting with Hasib, and we'll go around clockwise.
Yes, I think, just want to crystallize and go maybe in my closing comments, go back to something I said when I started, which is that over the next 20 years, this is going to be the largest crisis that many governments and healthcare systems are going to face. So my recommendation is that building on many of the earlier commitments we've made in this space, I really urge the G20 to invest in healthcare systems to better improve and manage cardiovascular health and risk factor management. And we're going to do that, I believe, by really developing innovative, strategic public-private partnerships between policymakers, healthcare systems, and private industry to make really meaningful, sustainable reductions in the number of heart attacks and strokes globally. So for me, it's strategic public-private partnerships.
Excellent. Thank you. Very, very clear recommendation. Matthias.
Yes, I think a major step will be for all countries to implement national action plans against cardiovascular disease, similar to what we have seen in the past successfully done in the area of cancer. And to set the pace for that and really set the standard and be ahead, I think the G20 should take this opportunity to formulate a G20-wide action plan to tackle the rise of cardiovascular disease, including measures, explicitly including measures to enable earlier diagnosis, early detection of disease in order to intervene and prevent against cardiovascular disease earlier.
Excellent. We heard that the cancer community has been extremely active and very successful. Moonshot projects, we talked about, there were examples of the Manhattan Project. So why not G20-wide action plan for cardiovascular disease? Let's be ambitious. Excellent. Thea, over to you.
Thank you. I guess thinking again about G20 and their past and how they came to be, and also understanding that they have the World Bank and IMF behind, and then it used to be pretty much the finance ministers club. And it's only in 2017 when they opened it up to health ministers and they started having health ministers meetings. I'm optimistic and a little bit pessimistic at the same time, because when we come down to only health ministers, then things kind of get watered down and it again becomes only health sector's business. I think that referring back to health ministers and finance ministers, as well as the World Bank and IMF, and picking up what the colleagues just said, I think investments, increasing investments for health in general, and then prioritizing within these health budgets their greatest disease burden will be #1 priority. And another one, something that's actually very dear to my heart, and I think that raising future generations and investing in them is the best investment you can have. And then I would link that with, again, it's just my own project, I have to say, the Global NCD platforms, where at WHO we're more focused on partnerships and stakeholders and actors rather than just specific disease areas. And we started this program, and I hope that every government picks up on this implementation research, because this is what we really need to do more of, and particularly helping young researchers building this critical mass of PhDs and master students and whoever is relevant, who will be able to do country-specific research, because homegrown researchers, they do care about this. And I think that investments should be also available, and grants and all the support. And speaking of academia and Rifat, hopefully you would also support this, and also partnership with Western and Eastern and Global South and North universities. They're very strong, and they have an enormous convening power of bringing all the partners together, and somehow these academic collaborations tend to be very happy and resourceful. So I think this is something I would put on the agenda.
Thank you. So higher investments for health and prioritizing these investments, but strategic public-private partnerships, but inclusive ones, including academia, of course, and I would support that. Kosh, over to you. 30 seconds.
Okay, so my request to Hasbullah would be for the G20 to establish a task force, really to give the right strategy and direction. And to Has's point, you need to choose the right pilots. Yes, there are a lot of pilots, but they're all flying Airbus A320s, the little short-haul ones. What you want are the pilots that are flying the Airbus A380s that take 600 people and go a lot further. And those are the pilots that you want.
Excellent. Well, Hasbullah, you've got a set of recommendations, and you've heard the discussions. We'd love to have your concluding remarks.
Thank you, Prof. Rifat. Yes, in this session, a lot of numbers, calculations came out. I will not repeat that. But what I am thinking is that why so many people still don't get access for this. And I think even the low-income people in my neighborhood understand that the NCD, heart disease, sometimes sudden death are frightening. But why don't they behave to reduce that cost? That's in my view from this discussion. Why not the COVID can? Why not getting more attention like COVID? That because the NCDs, the nature of NCDs, the relationship causal effects, the long term. So people don't see it as a dramatic like COVID. Yesterday they still talk to me, and then get disease, and then next week they die. So that's created, a fear of the people, and get even politicians and budget makers, and they pay more attention. In addition to that, the media coverage is making that kind of attention consideration become bigger. But NCDs, well, this is slowly increase. We have many indicators. We have technology, both in diagnostic, a lot of that diagnostic. We have the screening. We have facility, although you are right there, the supply side might not be equal across different, even in the developed countries, there's disparity on the supply side, but distance and communication technology can bypass that. But why still not there? The data is already everywhere, right? And the technology of managing data, big data, I think Prof. Gupta understand that better, still there. We identified knowledge, science, data already there. What is the risk factors, right? And the question is why we still not good enough? There is something that we didn't touch here, which is the effective communication between us, health professional, the doctors and the patient, we and the policymakers might be not good enough, our communication. And therefore, I think we have to reset our minds. Both of us, a health professional, doctors, relationship doctor to patient, to change the communication with doctor to patient, to change the patient behavior, to understand that prevention can be done, few diet activities and so on. So that's, I think, there, but how we communicate with the politician, with the high-rank policymakers, that will be taken from your recommendation next week to the G20 leaders. Thank you.
Excellent. What a super summary, which leaves nothing for me to add. Thank you, Professor Azbulaterbrani. So I won't add, except to ask you to join me in thanking our outstanding panelists in this session. Thank you. And we're on time.
Perfect timing, Rifat. So, colleagues, thank you so much. I'd like to thank the panel too for a very, very interesting session. And we will incorporate your ideas into the final conclusions. I'd like to invite now the final panel to join me. And I don't know, is Hanan here yet? Yes? Don't know whether she's arrived, who's going to chair this. Or perhaps she's not going to chair it. And then we need Adam Zerda, Henry Skinner, Mark Gitzinger, Kevin Otterson, and Najat Mokhtar. Thanks very much, Rifat. If you can bring in, if you've got your name plate, it would be helpful. Good. And just organize yourself around me. For Hanan, yeah, thank you. So colleagues, what I'll also do, I'm just looking at my staff. Are we going to hand out the draft call to action? 5 minutes. So what we're going to do, it is a draft, but the staff will share with you the initial call to action. It doesn't have the detail, obviously, for the cardiovascular disease panel, because I was furiously writing down the recommendations that came forward. And it doesn't have all of the recommendations for this panel on AMR. Now, Hanan Balki is a clinician. I can tell you, I got to know her virtually during COVID, and I can tell you I'm incredibly impressed by the energy and the ingenuity that she has brought to this portfolio as an Assistant Director General of the World Health Organization in dealing with this growing crisis. So Hanan, the floor is yours. And then James Anderson, the Executive Director for Global Health from the IFPMA, will sum up at the end of this session. You wanted a copy of that, I think, didn't you?
So no breaks for you guys, right?
No break. We're going to finish. We're finishing early and going to have a glass of wine after this is over.
Okay, so I think I have everything in order here. Thank you very much, ladies and gentlemen, your excellencies, people joining us online, colleagues, friends. It's such a pleasure to welcome you at the WHO, have a face-to-face meeting and seeing all of you and seeing you, Alan. It's really a true pleasure. And I want to thank you for organizing this, and especially in our own home, which makes it much easier and convenient. So thank you very much. And I'm very pleased to have some really esteemed colleagues with us on the panel today. So I think just very quickly, we have Adam Zerda, Senior Director, International Affairs, Becton & Dickinson, Henry Skinner, CEO, AMR Action Fund, Mark Gitzinger, I hope I'm pronouncing the names correctly, CEO, co-founder of BioVersus, and Kevin Alterson, Executive Director of Carbex, and Najat Mokhtar, Deputy Director General of Nuclear Sciences and Applications, International Atomic Energy Agency. So thank you very much for joining us, and it gives me great pleasure to be here. with all of you to talk about a very interesting topic that has kept us busy for quite a while. Yet it still got a bit swept away with the pandemic, but that's fine. I would like to thank the presidency of Indonesia for ensuring the high visibility also of antimicrobial resistance, which is among the top 10 public global health priorities. And thank the government of Indonesia for the AMR side event that we had last month in the presence of the Deputy Minister of Health, with the endorsement of Mr. Budi, His Excellency the Minister, but also with participation of the Ministers of Agriculture, Marine Affairs and Fisheries, Environment and Forestry, for their engagement at that side event in Bali, and the many partners that are here also, they were at the Bali event. But I think what was important in that specific event is the progress that was shown by the government of Indonesia and the importance and relevance of the multi-sectorality. And I'd like to take note of that and congratulate them for their progress. We all know, and those of you who are in the room we are probably the most passionate about this topic, but antimicrobial resistance is more of a phenomenon. It's not one disease. It's when bugs such as bacteria no longer are killed or stopped in their tracks by an available or what exists in treatments. The recent estimates of antimicrobial resistance directly attribute to 1.3 million human deaths from 2019 data. And that has been a harsh eye-opener. For me and for many of us who worked at the bedside for many years, it was not a surprise. In fact, I might comfortably say that I think it's an underestimate. But the data also shows that 5 million deaths are associated with antimicrobial resistance. The WHO is prioritizing the launch of the AMR national surveys to better keep our fingers on the pulse for AMR and to set the stage for assessing trends, spread of new resistance mechanisms, and to assist in supporting evidence-based policy and intervention. The numbers on the deaths and disabilities that can be produced through these surveys are a crucial centerpiece for the global response to AMR, including drug development, antimicrobial stewardship, infection prevention control, access to care, but also access to effective and affordable treatments. So I would like to acknowledge the document, Alan, that you had produced in a previous G20. If you can't measure it, you can't fix it. And I think I have a copy of it. I think it's important to understand that for AMR, we're still missing the case investment. There's a lot of work currently taking place to look into the economical impact of AMR. But I think it will be impossible to do so if we don't really know the cases of antimicrobial resistance that are taking place, specifically in the human health sector, but also in the other sectors. So I think in the AMR side event in Bali, I mentioned 5 major gaps. A gap in governance for AMR, knowledge gap, diagnostic gap, the investment and development gap that I'm referring to. But I want to emphasize again the transparency gap. The COVID pandemic has taught us very clearly that transparency in data and information is important. There's not one single entity or government or sector that can or should be implicated for public health issues, because if we do shy away and hide from our data, we will not be able to be transparent in putting forth the solutions and the interventions. So that's one gap that I hope that we can that the pandemic will allow us to overcome and allow us to comfortably talk about our data, especially when it comes to difficult data to address at the country level, because at the end, it's one global community. So in this session, we will highlight the importance of antimicrobial resistance and working together as the private sector, governments, multilaterals, understanding the success and challenges and the importance of such engagement and its importance so that we do not lose decades of advancement in modern medicine. One of the pandemic's biggest lessons also was to ensure equitable access to effective and affordable treatments for infections with robust and resilient healthcare systems. So with that, Alan, is it okay to start with the actual session? And maybe to start with, I would like to give the floor to each of the panelists for a 2 to 3 minute introduction of who they are and their background. So we can start maybe from the right hand.
Right, thank you, Hanan. And it's really a pleasure meeting you and meeting the colleagues here in this panel. Yes, absolutely. I think antimicrobial resistance is one of the top public health threats and priority, but without funding, it's the poor priority. Unfortunately, we know that addressing exactly what you are saying, you can't measure, but you can't fix what you can't measure. So we need data and we need information on the patterns of and the impacts and why we have the resistance to antimicrobial substances. I think we are focused here on the human interface, human-animal interface, but I think that we need also to look at the global picture. The antimicrobial substances, they go beyond the human health to the environment, to the soil and water, to the untreated water, and then goes to the agriculture and back to the animal and to humans. And we need to understand these patterns, and we need more data on this. At the agency, we use nuclear technology and isotope technology, and what we are doing is really tracing the fate of the antimicrobial substances in this cycle. And we are doing this with many countries, 25 countries in one of the projects with FAO, co-funded with FAO. And we welcome any other interested party to join, because here I think we will have more information, not only on the human part, but also animal and environmental part. One other aspect that we are looking at are the fake pharmaceuticals, that they add also the burden to this. And what we are doing is we are building a database on like fingerprinting on the real pharmaceutical, and so that we can immediately identify the fake pharmaceuticals. So this may also be ease the burden on this resistance being developed. Another aspect that we are looking at as well is how to break down the cycle, and for example, looking how we can treat water with ionization so that we can break down the molecules, and then the water being used in the agriculture can be safer in terms of antimicrobial substance. So in a nutshell, we need more data, we need more capacity building, and we need more funding and more research. I'll stop here and maybe I can continue afterward.
So I'm gonna skip you for a little bit, right?
I better hold.
So I'm Adam Zerda. I lead international affairs for BD, or Becton Dickinson. We're a large medtech company. Unlike most of the other colleagues here, we don't make pharmaceuticals or drugs, or are involved in discovery of some of those. But we certainly are very involved in diagnosing patients and ensuring that they receive the right treatments, most of the time through devices that we manufacture. And so we've been working in AMR for about 5 or 6 years. Actually started on this journey when the UN held a high-level meeting on AMR. And when we looked at what the WHO was driving, and the strategies that the WHO is describing, including diagnosis, including infection prevention, including appropriate treatment of patients, we saw a lot of that reflected in what BD is doing. And so I'll talk about some of the impact of our work, especially on data, I think, in just a little bit. But do encourage you to think about the role of medical device technologies and medtech companies in partnering with you, certainly at the country level, on implementing programs related to infection prevention, related to diagnosis, related to treatment. The more of these programs we build, the robust they are, more sustainable they are. Certainly it affects you, it helps you, and certainly we benefit from that as well as a private sector company. And those types of partnerships that will help achieve goals for our patients, for your populations. Those are things that certainly we work on, and I think most of the other partners here do as well. Thanks.
Hello, my name is Kevin Alderson. I'm a professor at Boston University. For the past 6 years, I've led CARB-X, which is a new type of public-private partnership that takes money from our funders, 3 governments, the US, Germany, and the United Kingdom, and 2 foundations, Wellcome and Gates, and turns around and then scours the planet working with all of the small companies around the world in which there's amazing innovation occurring. The average size, honestly, the median size of the company that CARB-X works with is less than 10 full-time equivalent employees, very small, and works with them to find that innovation in both therapeutics, diagnostics, as well as prevention from anywhere in the world, and to take those ideas, out of the universities and out of the small startup companies, and to bring it to a point where we have some proof of safety in humans at the end of the phase 1 trial. Because we've looked at the pipeline, not just us, but WHO and really everyone who's looked at it, of antibiotics in the world. And I think the one word that would describe it is inadequate or fragile. You pick one. I like to think of effectiveness of antibiotics globally as an asset for everyone, an asset for civilization. Think about a brand new building that you build or a new car that you buy. And then stop maintaining that car for a decade or 2, and what will happen to it? It won't be good. When we first brought effective antibiotics to the world in the 40s, it was a beautiful thing, and it was new and shiny and worked well. Penicillin is a great drug. But today, think of penicillin or think of any effective antibiotics or just antibiotic effectiveness generally. Think of it as a dam that has not been maintained for 4 decades or has been under maintenance for 4 decades. That risks catastrophic failure. I think that's where we are. And the mission of CARB-X is to do all of that deferred maintenance on the pipeline, not just on behalf of our funders or the G7 or the G20, but really on behalf of everyone.
I'm Henry Skinner. I'm the CEO of the AMR Action Fund, which is also a public-private partnership. It's the largest public-private partnership focused on clinical development of the pipeline and with a priority to the WHO priority list and trying to focus on the most urgent needs. As Kevin said, the pipeline is thin, and we're taking it from roughly where Kevin brings it and trying to bring it through the clinic and to patients for benefit worldwide. So our focus is late stage. We really try to help the young innovative companies, and they are small, so 15 to 30 people typically for what we invest in, to bring a product through regulatory in the US, Europe, and ultimately around the world for patient benefit, and really focus on helping the entrepreneurs and the innovators, not only with capital to do this, but also insight and how we need to do it, where we need to bring it through, what indications, and so forth. And really relying on the data from what WHO does and others to understand where we should be developing the drugs. And I think that's a key point. For us, we look at roughly a decade of R&D to bring a new antibiotic to market. That means we need data for what these pathogens are, for what they will look like 10 years from now. And that data needs to be robust, and it needs to be from around the world so we know, A, what to make, where to take it, and where the patient benefit ultimately is.
My name is Mark Gitzinger, and I represent as CEO the company BioVersus, one of these SMEs that is working in the field and developing 2 phase 2 clinical products, one against tuberculosis and one in ventilator-associated pneumonia from gram-negatives. But I also represent the SME community on a larger scale from Europe and Israel as president of the BEAM Alliance. And why are SMEs so represented in AMR panels, and why are they important? We heard it a little bit from Kevin and from Henry, but 80% or more of the global pipeline of novel antibiotics, clinical and preclinical included, are in the hands of small and micro companies, not medium-sized. And I think that alone is totally alarming, because we heard about the fragility of the amount of drugs in the pipeline, but the fragility of who owns these is another aspect, because most of these companies not only have few employees, meaning few people that actually have the know-how to drive these drugs forward, but also they have a financial runway of normally maximum 12 to 18 months. And that's what we as society, as Kevin has nicely put it, are relying on to actually deliver drugs that all of us and our medical healthcare system needs nearly on a daily basis. So I think that is totally alarming, and we have come a long way. So that's the positive note, because we have initiatives like CARB-X. We actually have initiatives where also the private sector comes really back in, like the AMR Action Fund. And we have even some of the larger companies coming back into the field. However, we still have a real big conundrum to solve, and that is the economic model around how to handle antibiotics when they are actually successful coming forward. And I think here, that is my big pledge. We really need action now, because an effective economic model would actually trickle down into all of the R&D areas, into the sustainable use areas, and also into the data area of actually generating or knowing what is happening out there. And actually, we can design these models, and we can design them to make sustainable use a matter of the model by delinking the sales volume from the revenue. And I think that is one big thing that I want to discuss on this panel.
Thank you very much. And I think, thank you for the introductions. Maybe we've touched in your introductions on some of the areas we want to go into, so then you will dive a bit deeper. So I think talking about the data, as everybody has been mentioning in their introductions, the data is probably the first step to be able to move forward. So my first question will go to Adam. The diagnostics, as we all know, play a critical role in our fight against antimicrobial resistance, and the innovation and access to high quality and affordable agents are extremely important. My question to you is, what should be done by both governments, in your opinion, and the private sector to boost the role of diagnostics in the fight against AMR?
So appreciate it. I know we've been talking about this for a little bit. In fact, we've been talking about it a lot here today. I'm not going to try to bore you with numbers, because you probably won't remember them anyway. But here's what I will share. Data is incredibly important, but even more so is the insights and then the decisions that data informs. So the insights might be things like, holy cow, I had no idea that AMR was this big a problem. And until we had the Lancet report earlier this year, we had some good estimates. And the Lancet report put a stake in the ground and said our estimates were actually not that good, and the problem is a lot bigger. Problem is, the Lancet report is a fantastic report. It is based on a vanishingly small amount of real information that translates the prevalence of drug-resistant infections in humans to outcomes, to deaths, right? We have pretty good data on how big a problem AMR is in patients. We don't know how many patients actually die from a drug-resistant infection. That is really hard work. Reason I know that is a good portion of the data that went into that report was provided by BD to IHME, and it was largely based on a US database. And so why is that? Why did that happen? Why is it that it's such a small database? Well, first, you need big electronic medical records that compile this stuff. Only a few countries have well-connected electronic medical records. You also need to have data from laboratory information systems that are available that you can link to those EMRs. So electronic medical records holds patient information, including outcomes. Lab databases control or contain information from the lab, from the diagnostics equipment. So you need to pull that together. And they need to pull in information potentially around costs. That is not happening around the world, and it certainly isn't happening in low and middle income countries. It's not happening much even in Europe. Where it was happening in the US was around the database that BD set up. It was actually a small company that eventually became part of BD. that help automate the way that hospitals reported information into the US CDC. And so all we were is a go-between, a pass-through. We automated the way that hospitals pulled information from these various databases and then submitted it to the US CDC. Vast majority of the customers that use that software tool that BD has have acknowledged or have allowed for data rights for research purposes. So BD doesn't mine this information. We allow research organizations to get involved and take a look at it. And IHME was one of those. The US CDC was one of those. What that data enabled was incredible insight around the impact of AMR, but again, in a very small subset. So Hanan, to answer your question, one thing that governments should do is encourage broadly reporting of AMR data, not just of prevalence of infection, but outcomes. Hospitals can and should increasingly report infections, HAI rates, and the impact of those infections on patients. They should also be reporting things like sepsis. I know we talked about that earlier today, and CVD. That information is vitally important to draw insights. But it doesn't have to just be in tightly controlled mechanisms that only a government has access to, because oftentimes those databases are not transparent. The US CDC certainly is, but it also allows for the type of work that BD enabled through the work with IHME. I would encourage broader use of those types of measures. It's not a ploy, if you will, for BD to have more business elsewhere, because frankly, we're not looking to try to translate that software into multiple languages, but it does generate incredible insights. And just a second quick point on data and information. It can't just be global. So data that feeds up into a national database for surveillance, yes, it's important, and yes, it's helpful for ministers of health, ministers of finance, potentially for the WHO, and for many of the companies that are looking to discover new drugs. That data is vitally important for patient care. So the same information that comes from a diagnostic test should first and foremost inform clinical care. It should, in my opinion, second, inform regional information around prevalence of resistance within that hospital or within that region. So that's an antibiogram, and then ultimately feed into that surveillance system that helps inform policy and advocacy efforts.
Thank you very much for the very valuable comments. And just to emphasize that even the WHO is talking about patient-centered data. So it's not about surveillance for us either, because if we want representative data, it has to be related to the patient care. So the patient needs to be at the center. So thank you for those very valuable comments. And we will definitely have to come back to you at the end for some further insights. But dear Najat, the AMR is complex and affects not only humans, as you mentioned, but also animals, plants, and the environment. A comprehensive multi-sectoral response, as we have been talking about since 2015, is extremely important. My question to you is, how do you think the One Health approach supports the comprehensive response to AMR, and what needs to be done at the global or national level so that we can move forward in a more leaping instead of crawling? Thank you.
I think, yes, the One Health, the quadripartite is the right approach, because it's unifying approach aimed to sustainably balance and optimize the health of people, animals, and ecosystems. But one element that is important to also help the quadripartite and the One Health approach is also raising awareness about the issue. We need to bring agriculture people, animal health people, human health, the private sector around the table to discuss how to address this issue together. And also the problem with the antimicrobial resistance is not one size fits for all. Each country has its own issue. So we need, again, data at country level, and we need to to enhance this awareness about at country level. We need the data, but it's like a vicious cycle, because if we want to raise awareness, we need to show it to the country, and we don't have data. So I think also capacity building at country level, enhancing the capabilities of bacteriology laboratories to do proper analysis, to also be proper reporting, like what we are doing in animal health. I mean, through the World Organization of Animal Health, we work together to do proper reporting on what is going on animal health. So on antimicrobial resistance, we can do exactly the same mechanism, reporting mechanism through the One Health, through the One Health. Again, also, the money is always the backbone of everything. So supporting the One Health approach and supporting the quadripartite, we need financing as well. So that would be a call that we can do at the 25. Thank you. G25, sorry.
Thank you very much. Going to Henry, the WHO, as you know, salutes the private sector for creating the AMR Action Fund. It was a very exciting moment, and we're very proud of its creation and the progress so far. As we all know, AMR does not respect borders, especially in this interlinked world. So my question is, how will AMR Action Fund ensure the access of the 2 to 4 antibiotics that are envisaged for 2030 to all who will be in need of these agents, including the low mid-income countries? And is it something that we can and should start be working on?
Hanan, thanks first for the WHO's support in starting the fund and helping us intellectually put it together. It certainly wouldn't have happened without the support. Let me frame that question with part of the challenge we face with these companies. And just to remind you, these are small companies, perhaps 30 people, with very limited capability, more limited experience, right? Probably in all of our companies that we'll invest in, no one will have had experience providing access to approved drugs in the low and middle income countries. So we need partners for this. We need to find partners who have that expertise, who know how to do it, who have the contacts, be that local companies, regional companies, multinational NGOs, and others to support us in that. One of the things we are doing is we are bringing our companies to form access plans. We are connecting them with partners who can contribute knowledge and know-how and are developing expertise in this area, groups like GARD-P, local and multinational industry partners who can help that planning and anticipation of that. But beyond that, we going back to data, we need the data to know where we might have this impact. Where is the greatest need? Where is the prevalence? Where should we be thinking about conducting studies to really understand the potential of some of these drugs to fit some of these needs? And frankly, from our standpoint, which should we prioritize to have the greatest total benefit potential? And having access to that data broadly, having that access to the data contemporaneously so that we have the anticipation of where it needs to go, so that we can foster the right connections, and frankly, so that we can work with the finance ministers to justify the burden of these diseases and the impact that our approach can take, both locally and internationally. And so at the end of the day, we can do so much. We don't have the resources to drive the access. We need partners, but we can help foster that and make sure there's a plan in place. And with the data, we can articulate the rationale and the economic benefit that will justify the investment to bring access much more broadly.
Thank you very much. I think we might have comments from the audience later on the access issues, but we can dive into that a little bit more. But I'll go now to Mark. The small and middle-sized, or SMEs, are critical in our quest for products, as you very much elaborated on in your introduction, but they face very different challenges. I think what are the key challenges of these enterprises, and what else can the international community do to assist? And maybe I want to add a little bit of a twist after a discussion I had with both Kevin and Henry. When we talk about the science in R&D, if it's not maintained, we will even lose the scientists that are capable of doing this. And I think this doesn't even come to the surface in regular discussions. And the description of an old, what did you say, Kevin? An old car? Or did I say, yeah.
The car you don't maintain.
The car you don't maintain, exactly. I think those were the scientists, right? The scientists or the drugs, because even the scientists need to be bred up. You need to bring, again, part of my previous work was in science or in academia. And it does take years. If it takes a decade to develop an agent, it takes years to develop scientists. And if we're going to lose the investment there, then it's going to be a problem. But I think that if you can give us a little bit more perspective on your thoughts on that, and then maybe we can start opening the discussion, please.
Yeah, thank you. I think this is a very important point. And what challenges do we face as SMEs? Number one, I think we face the challenges that every pharmaceutical company faces in developing a new drug. It is not easy. It is high risk. But there's a few add-ons in the AMR sector. It's a very small community in the meantime. And this brain drain that is starting to come up in some of the discussions is actually very important. Because if you look at it, we have very few experts still that really know how to develop drugs. And the community is so small that we probably can name nearly everyone there around the table here very easily. And we have very few talent coming after that. And besides that, the challenges that we are still facing when we would be successful with access, for instance, ensuring stewardship, etc. Here we are totally dependent on the public-private partnerships. So it is absolutely important, as Henry said, that we have institutions like GARDP and others to actually help. Also, the AMR Action Fund and CARB-X is helping in the brain drain a little bit because they actually collect all of these expertises. That's great. But one or two challenges that we have on top is access to clinical trial sites where the problem is really big in good quality. You know, we're running trials on AMR in high-income countries where you have to actually go and search these patients still in the intensive care units, while we have actually hundreds of them in other countries where we could actually do much better trials. I think that's an aspect. And the last aspect, and that's very frustrating, I have to admit, because even when you go through all the struggle and you manage to bring the drug forward, the thank you that you get is bankruptcy. And that is really not acceptable. And I think here we have had, basically in all panels, we had the ask for more funding. I understand that. But I do believe, and I want to maybe make this comment here, and do a provocative argument, do we actually need more funding or just put it in the right spot? Because AMR is already a pandemic that is ongoing. And the cost, especially to high-income countries, to correct all of the things that happen to a patient suffering from a resistant infection, longer prolonged hospital stays, eventually death, all the follow-up treatments, etc., that has a cost. If we would just shift that to ensuring that we actually enable a working market in the high-income countries for antibiotics that could fund this, I think it would be feasible. And to put a number behind that, I cite Kevin that has calculated that roughly $5 per person per year would buy us this insurance to have new antibiotics available. And I think that should be worth it for the high-income countries to make that happen. And really thinking of not putting additional money, but putting the money that is already spent on correcting to enabling new drugs being available when we need them. And like this, also making them available globally, because they are global assets that actually benefit every society.
Thank you very much. These are very valuable arguments. And I think that we've, as you can see, when we do talk about AMR, we end up becoming fragmented, and then we try to come together again, and we become fragmented. And I'm being very honest here. I think when we keep talking about the investments without understanding and keeping our finger on the pulse with the problem, how it's evolving and what's happening with the actual pathogen itself that as you said, from the very beginning of the penicillin discovery, resistance was identified. And resistance will, unless, and I've asked colleagues around this table, do we foresee soon an antimicrobial agent that is totally bulletproof to resistance? And it's no. So if that's the case, then the investment in understanding the magnitude of the problem on the ground in the countries is going to be a continued necessity for us to continue to address the AMR response globally. And that's where we've doubled down in the past 2 years at WHO, and we've produced the national AMR surveys, and we're really hoping and calling for support to be able to at least pilot them, but also to roll them out in a larger number of countries so that we can start investing in the patient-centered approach for diagnosis, specifically with a focus on the bacterial infections. And that will continue to keep the fire under all of the entities that need to be fed. Because if we ever lose the argument about why we need to do this, why do we need to produce new antimicrobial agents, why do we need to do surveillance, we will never be getting the funds nor the expertise unified around this cause. So I think that would be one of my major calls to action, to be able to serve all of the agendas, whether it's funding for implementing national infection prevention control programs, funding to implement stewardship and access programs, funding to very much close to my heart as a clinician, so that I don't stand rubbing my hands at the patient's bed with no antibiotic to prescribe. And as a past physician, that is the most difficult position to be put in, is to see your patient dying. And not so in low-income countries, sometimes there's even no access to the first-line therapies. And in high-income countries, they have lots of antibiotics, but they're all ineffective. So I think to re-emphasize the issue of patient-centered diagnosis, so that we can have a science-based information for policy development, but so that we can also help in building that capacity for the laboratory diagnostics that can feed into surveillance, so that we really have the horse before the cart, and the patients come at the center, feed into surveillance, feed into global data, and not the opposite. So I think I'll stop here and yes, and we can take open for questions.
Yeah, I just want to make one point about the discussion that we had with Baroness Scotland, with Patricia Scotland, and you heard her when she did her. I still can't get my head around this idea of fireside chats, given that there's no fireside. But there we go. When she had the fireside chat, and then when she spoke at the dinner last night for participants, there is a new accord agreed between the World Health Organization and the Commonwealth. And she said at the dinner last night that, and not to be misrepresented when I say this, but what she said was she's happy for the Commonwealth, to be a testing ground for new tools when it comes to treatments. The other thing, of course, is that the Commonwealth, with its 56 countries, has a very wide range, very diverse range of countries, everything from the richest to the biggest, like India, to the smallest and to the poorest. And I do want to pick up your point, Hanan, on this issue of measuring, because in the 6 years that we've had this partnership, every success that we've had has been working with either product development partners or with others in the area of health. And the starting point has been to measure what the scale of the problem is. Because, and Elmar Brock, who's one of our senior advisors and ambassadors, and chaired the European Parliament's Foreign Relations Committee, he was the longest serving chair of that committee, will speak in the roundup at the end. But Elmar knows, and the other politicians here know, that if you're not a health specialist, then you've got to have some absolutely bomb-proof data if you're going to get the finance to be able to do some of these things. Now, I think we've done it very successfully working with FIND, for example, in many areas on diagnostics. During the pandemic, we worked very closely, largely to the thanks of Hatice, with CEPI to get to take the arguments to countries about the need for funding for the development of the vaccines. And the point is that in our interface with finance ministers, they do listen if you can point to something very concrete and you say, look, this is not just on the back of a fag packet of cigarettes, not that we do that now, but this is actually proper evidence. And having the International Atomic Energy Agency involved, and having the World Health Organization involved, and having the private sector involved, and then CARB-X and the fund, I mean, you've got a really powerful advocacy group there. But you've got to get the data. And so one of the things that I do think you should consider, and we would help you with this because obviously Patricia is a very close friend of the partnership, is to see whether she would help the World Health Organization gather or introduce a mechanism to measure the incidence of antimicrobial resistance in a group of Commonwealth countries as part of the MOU that's now been agreed with the Commonwealth. But the thing is, Henry, it's going to need to be paid for, the study, and I say that to James too, but we need to do it urgently. We can't have weeks and weeks and weeks discussing it. If we believe that data is absolutely fundamental, and that's what's going to get this whole thing moving forward more effectively, then we need, with the help, Hasbullah, with the Indonesian presidency, and we can discuss it next week in Bali at the T20, we need to move quickly. We need to get a group of countries doing the national analysis, launched during the Indonesian presidency, and those results need to be presented to the G20 and the G7 next year. And what we then need to do is say to these finance ministers, you've got the evidence and now you've got to start funding something. So I do think there's a real sense of urgency, and the G20 Health and Development Partnership will, I give you this commitment today, we are committed to working on the NCD agenda, because we see that, and we heard that in the previous panel, is another massive juggernaut coming down the highway. And we will work very closely and in a very sustained way with you and the people around this table. And I don't know whether Peter's here from GOD-P, but we work closely with you too, to make sure that we get a step change in the way in which this policy is being handled. I find it very frustrating that at the first health ministers meeting in 2017, organized by Angela Merkel, when this partnership was created, we were talking about antimicrobial resistance. And I turn up at every health conference and we talk about antimicrobial resistance. And there's great people who are committed to it, but we've got to get that evidence, and then we've got to hammer it home with the heads of government and the finance ministers.
Thank you very much, Alan, for the commitment and the support. And I'm sure most of us here would be very supportive. But I think I need to post my last question to Kevin, because I kind of lapsed on looking at, so I do apologize. And it does fall within your comment as well, so it's really timely. So Kevin, I think we were talking about the public-private partnerships. How should we use the lessons used from the COVID-19 response to shape our approach to the public-private partnership in R&D for antimicrobial resistance from your vast experience, please?
Well, thank you. We benefited in COVID-19 by having had decades of other research to have the messenger RNA vaccines close to being ready. And then we benefited from just almost an unlimited market, governments making commitments that if you bring this to the market, we'll pay for it. And even we'll pay for, you don't even have to do the phase 3 and build your plant at risk, with the exception of Pfizer that did it themselves. But most of the companies, the government took that risk too, and things moved quickly. For antibiotics, it's been 4 decades since we had the discovery of a product against gram-negatives that has led to an approval by a major drug regulatory authority of a new class. There's, again, the clinical pipeline is thin. We work in the preclinical pipeline, but from the moment something begins a human trial to the day typically that it's available for patients, it's going to be 6 or 7 or 8 years. And even worse, we, Kohlberg looked maybe 4 or 5 years ago, wrote a paper on what was of the antibiotics that were approved by EMA and FDA, how many of them were getting to middle-income countries? And the result of that study was not very many. And I looked at that and said, well, what about high-income countries? And when I did that study, we looked at the G7 plus 7 other high-income countries in Europe. And the results were shocking that for the last 18 antibiotics approved by either FDA or Canada or EMA or Japan, that the majority of them were not commercially launched even in countries like Germany. And at the bottom of the list was Japan and Canada, okay, with only 2 out of 18 in Canada, okay. So the point is that, if you think you want antibiotics to be available when they come to the market, if the existing system is not even getting them commercially launched in places like Japan and Canada or Germany, then you have a fundamental problem. I think the rate limiting step in this whole area is not science. The science is strong. There's been a lot of great money spent. Rate limiting step is economics, changing the way we pay for antibiotics so that we actually pay for what we're hoping for. Okay. So, I think that I want also to speak to health ministers, but also the finance ministers. The reason why I used the analogy at the beginning about an infrastructure asset or a car that you failed to maintain or a bridge that you've ignored, a dam for 4 decades, is that they do understand the idea of assets that need to be maintained. This asset, antimicrobial effectiveness, is on nobody's balance sheet. Nobody feels a responsibility for maintaining this, and we're getting exactly that. For most other categories of drugs, you don't need to maintain the class. For this category, because of bacterial resistance evolution, we have to maintain the class to avoid falling back. And so if I could get that attitude over, it's an asset. It needs to be in the balance sheet. We need to be maintaining it. Then the actual money that's required is modest. The estimate that Mark said of $5 per person per year, that's for US people. It would be less for other countries. It's really the equivalent of 1 Starbucks a year per person in the US. Not in Geneva. Okay, maybe they're more expensive in Geneva. But the point is, it's the most important drug class in human history. We have a choice of either that or a Starbucks latte.
Thank you very much. I think now I don't know how much time we have left, Alan, but maybe we can take some questions. Before I give the floor to Mark, maybe any comments from the audience? Otherwise, maybe, okay. Yes.
Thank you. This is Tamer from Meta. I'm actually an epidemiologist by training, so super interesting. I'm wondering if you have in mind a specific sampling-based disease surveillance or AMR surveillance, collecting primary data that could be implemented if we had the funding this year, next year, something that can get us the information we need to drive sounder policy decisions.
Thank you very much. I guess the question is for me. So definitely this is, as I mentioned maybe quickly in my opening, is that we have focused in the past year and a half to develop the national surveys for antimicrobial resistance, and we're really eager to pilot them and roll them out. We already have an estimate of how much it would potentially cost in the different countries, of course, depending on the size of the country and the complexity and the infrastructure that exists. But the whole idea is, so the answer is yes, and we're calling for partners to help fund some of these countries to move it forward. And again, we've learned from the previous diseases, we learned from what took place in the TB world and in the HIV world, and we find that this would be one of the quickest and informative methodologies to bring data at the country level with keeping the patient at the center that will then mature gradually into sustainable data? So the answer is yes, and I'm really happy to discuss this further with anybody who is willing to engage. Thank you. Yes. Oh, that is.
Seeing no questions.
Okay.
I was just going to respond to Alan to some of the statements you were making around really a call to try to move this forward and really do so in a big, meaningful way. So all in, if that's something that we want to put together. Want to highlight though that it's not just around measuring prevalence of resistance. I think that's a doable challenge, right? I mean, yes, you'll need more diagnostics and more labs that know how to run them. And believe me, because we place a lot of diagnostics in a lot of these labs, a lot of labs don't know how to run them, or run them for a little bit and then lose interest, for lack of a better word, right? Because we know instruments are sitting there, and if the kit to use them is not being ordered, it's not being used, right? So unfortunately, that is a problem. All that aside, though, translating information on which patients are having which infections to how many of them are dying, how many of them are staying in hospitals too long, how many of them are coming back for recurring infections. In the conversations that I've had with hospital leaders, with hospital CEOs around the world, as well as in these types of forums with global stakeholders, that's what they need to see, right? Unfortunately, they need to see the impact on what's happening to their populations, what's happening to how much it's costing to treat these patients in hospitals, not just in dollars. Yes, it's important, or euros or francs, but how much it's costing in terms of, unfortunately, in lives. And that's a big part of this. So if the Commonwealth is interested in working on trying to figure that out as well, I mean, I know we know what data is needed to be pulled. Whether it's available is a whole nother matter, but you know, I know we had Google here and Meta here, and hopefully they can figure out some ways to scrape it from something. But pulling all that information together is going to be really crucial. I think that'll be a massive, massive step change in how we think about this issue.
And I wonder, Hanan, whether Najat has got the data for soil and animal information on this, because I do think that we want it to be as comprehensive as possible, and it's you know, we want to show that the impact is, I mean, it's across the whole of society, the whole, you know, the food chain, everything. If you've got that data.
We start collecting data with the member state that they are involved in this project. As I have said, we are now at the level of first capacity training and harmonization of the methodologies, and then I think end of the year we start collecting the data, and it will go. It's a project of 5 years, so that's no problem. I think with the team here, and we expand more, we will be happy to join, and even. We have also good mechanism in capacity building for the laboratories, how to analyze, how to report. We have been doing this for many decades, so we can join the team and do that as well. Yeah.
Can I raise one point on also what Adam said? You know, getting the data, we also have to remember that we actually stigmatize a fair bit the hospitals where we would get the data from, because most of these very severe infections are hospital-acquired infections. And right now, we also need to find, in my eyes, when we want to collect really good data, a way to not stigmatize hospitals, because actually these infections can happen in hospitals, as we know, also if you do best practice. And also to, you know, to give the motivation to actually share all of this data, to collect it and openly, you know, bring it forward. I think that is something we should actually not underestimate in this attempt to collect the data.
Just very quickly, again, that is definitely crucial what you're saying, and that's why we need to have another discussion with the technical people to dive deep into the surveys, because I'm giving a very high perspective of the surveys. The surveys are not just for antimicrobial resistance data. They're more comprehensive. And the whole idea is the patient-centeredness of it. Now, how this data, it's not supposed to be, the use of it to start with is to serve the member state itself, the country itself. It's not to exploit, it's not to show the global world where are the hot spots of resistance. And again, that was my previous job, so I'm very aware of that specific challenge. But I think that's why if we speak about the benefit of the patient first, that comes from the grassroots up, I think it should not be a problem and how it's being managed. And again, it's not to pool aggregate data, it's to enable, and within these surveys, once they are launched and if they can get picked up quicker than I think they are, is one of the biggest aims is capacity building for laboratory diagnostics at the country level, regardless of the methodology, whether it's the routine old-fashioned or the innovative ways or whatever comes down the path of diagnostics, whatever that is, then we need that capacity building now. And as we said, this is something that's not going to leave us for decades to come. So if we don't prepare for now, we will be having the same discussion. Even if we tomorrow discover 3-4 new antimicrobials, we're going to have this discussion again in 10 years. So I think it's time to really start on framing it from the country level up and not from the global level down. So thank you very much. Is that Peter Bayer or am I imagining?
No, you are correct, Hanan.
Okay, so he raised his hand, he's over there. Please.
Thank you so much, Hanan, and it's a great pleasure to be here. GARDP was mentioned a couple of times. We are a not-for-profit foundation based here in Geneva. We are developing antibiotics together with a small companies such as a Mark's company, and we are also providing access to those antibiotics in low and middle income countries. So we just signed a license agreement with Shionogi for a new reserve antibiotic. We have the license for 136 countries. And now we're looking for a manufacturer. So we have a request for proposals out there, and we're looking for a manufacturer for this new reserve antibiotic to deliver it to 136 low and middle income countries. And I want to reiterate, I mean, this is the research into the development of these new drugs is heavily subsidized by Kevin, by CARB-X, by Henry, through the AMR Action Fund, by GARDP. So there has been a lot of success over the past years in actually putting public money and some industry money in the R&D process. But even if we find this manufacturer, this generic manufacturer needs to recoup the investment that the company is investing in setting up the production, registering the drug, and shipping the drug to the countries. And that is where I think for the G20, there's a really important role to play, because this manufacturer should be in a G20 country. And it should serve the G20 countries. So it can be a win-win situation where you actually investing in your manufacturing capacities, it's pandemic preparedness, you are serving your patients in your countries. And of course, it needs to be a profitable market for that company, because otherwise we are not going to find anybody. So I think that's something where we really could work with the G20 over the next years to see whether there can't be more collaboration in that area. I mean, knowing you are totally right, asking for better data. But what we do know today is that the big disease burden is not in the high income countries, it's much more in the low and middle income countries. And that is where actually the drugs are needed immediately. And I think that is, we would really love to work with the G20 and you on this.
Thank you very much, Peter. And I think we've probably exceeded our time, and I would like to hand it over to James for final comments and conclusion.
Thanks very much, Hanan and Alan, for inviting me to be part of this panel. Last year at this summit, I had the privilege to chair this panel, in fact, and this year I've been promoted. So I now get to make the closing remarks. That being said, I do recognize that I'm almost what's standing between all of us and some cocktails outside. So I will be quick, I promise. I'm James Anderson, Executive Director of Global Health at the IFPMA. I'm going to make 4 comments, really. So first off, I do think we
whilst we all recognize the challenges that remain in this extreme global health threat that is AMR, we shouldn't also forget about the progress. So 10 years ago, 15 years ago, when some of us started work in this area, coming to a meeting like this, AMR would have been barely mentioned. Whereas, as we've noted, it's been probably mentioned on almost every panel yesterday and today. That's a really important sign of progress, and I don't think we should lose sight of that. It doesn't solve it, but it is a step forward. And that means that AMR has moved from the purely technical discussion that it was into a much broader policy, which is what we need. Second element of progress we should note versus this time last year is in concrete terms in the G7 in particular, which built on the UK presidency last year with Germany this year. The progress report from the R&D hub kept it front and center with the G7 leaders, and the progress of the UK pilot also has really moved forward in concrete terms. It's not enough, but it is progress. Secondly, we've all spoken a lot about preparing for the next pandemic or future pandemics. And we've heard some people actually describe AMR as a pandemic, as a current pandemic, right? That's been running for a number of years, even throughout COVID. So what I want to say is that as we think about preparing for the next one, we need to make sure that we don't just prepare for COVID again, right? Because the next one probably almost certainly will be different. We don't know what it is, which means we need to be preparing on multiple fronts, which for me absolutely includes AMR. So the three takeaways that I would summarize from a very rich discussion is first of all on the urgency point, which came out several times. And I believe that we do need to try to do things differently, because otherwise progress won't change. The direction of travel won't change. The industry, I'm so pleased, has stepped up and is doing things differently. We have 5 companies here that I will name check who've provided significant funding into the AMR Action Fund. We have Novartis, we have MSD, we had J&J, we have Pfizer, and we have Roche, all making very significant contributions. This is different. This is not what rival companies normally do, and that's because we recognize the urgency to act. The pipeline is not where we need it to be, but it isn't enough on its own. So it's critical that we change the economic model, as we've heard very clearly. And we do need that progress urgently. Once we get that, it will also fix a number of the other areas, such as the brain drain, such as the early stage companies as well. So the second takeaway is around how important finance ministers, finance experts are in health debates. That again has been consistent throughout this summit, but really came through strongly here. And I think we would all support the suggestion that was made for a more structured dialogue on AMR with the finance community, particularly leading governments, together with private sector and academia and so on, in order to compare and understand each other. What are the barriers? What is the progress we're making? So that needs a regular and structured process in order to make it happen. And third and finally, just to close out on this point on the data, again, that's been a real theme throughout the summit. I'm really pleased to hear of your plans, Hanan, with the national surveys. There is definitely a gap there in rich countries and in poor countries. We all agree if you can't measure it, you can't fix it. And so I would encourage the genesis of the debate here around what can we do together to support that initiative, get it moving forward, get it piloted. You know, let's go, let's do things differently. Thanks very much.
Thanks very much, James. So that's the end of this panel. I want to thank the panel members, but what I would like to suggest to Hanan and to those who are on this panel and others in the room, that we try and organise, probably virtually, a follow-up discussion as soon as possible in order to just action some of the things that have been said, because I think we now need, I think, to pull this together much more strongly and prepare for the next health and finance ministers meeting. And of course, next year Japan has the G7 and India has the G20, and so I do think we need to perhaps be a bit more dynamic and coordinated now on how we do this. So thanks to the panel for doing this work. Thank you. Can I ask Hatice and Elmar Brock to come up and join me and Hasbullah to conclude the discussion? We have, I think you've probably all got to circulate. We've circulated you the draft action plan. So this is something we've been working on, sort of over the last few days. And obviously it's a framework. There will have to be things added into it. And if you've got some concrete comments, then of course email us because I think a teacher and I are going to be finalising it on the flight to Bali tomorrow. So send us your information. So what I'd like to do is Elmar Brock, who is making his way up here. Come around here, Elmar, and sit. If you get your name, can you get your name plate? Oh, it's not necessary. Everyone knows you. Elmar, when I first met in 1989, when we were members of the European Parliament, I left in 2000. He continued on and has held some of the most esteemed positions in European politics. He was the chairman of the Foreign Relations Committee in the European Parliament for many, many years. He's been an advisor to Angela Merkel. He has supported the current Commission President. He's been an envoy on behalf of the Commission President and the President of the European Parliament, and so holds a very senior position within the international community. And he's now an advisor to the Munich Security Conference, which is growing in importance in terms of world leaders getting together. And he's been a great source of advice to Hatice and I and to the rest of the team, and has also been incredibly helpful networking us around the world, not just in Europe, when we've needed to speak to various figures. For example, he arranged the Zoom meeting that we did with Antonio Guterres in the middle of the pandemic, so that the partners could actually have a discussion with the head of the UN about what the UN was doing on the issue of equity when it came to the pandemic. So Elmar, you've sat through this, and I just wonder if you'd like to take some minutes just to give us your reflections as a very senior political figure.
Thank you very much. Senior or older politician. That's the problem. Thank you very much, Alan, Hatice. I have learned a lot in these 2 days, and a lot of things are very, very interesting. But sometimes I believe also, how would I translate it into political action where it's needed? So this step to that, and in which political environment it comes. I think most of the contribution had its good reasons, but how can it reach the political decision-making level in a proper way? And I think this became in one way easier because of the pandemic, but on the other side also more difficult. And I will talk about some problems which might arise still. I think in this pandemic, but also because of the Russian aggression, we have seen that the smooth, rule-based multilateral system might not work anymore. And that therefore, right or wrong decisions might be taken. And this is done because of pressure in our own population. We've seen that rich European countries were not able to give to its people masks because nobody could produce them anymore in Europe. That's lastly. And that has a simple thing which brought a lot of costs. We have a debate about this now in energy shortage. We had this debate in pandemic, not just because of the vaccines, but other molecular products. How much influence has Europe in the production of medical products? How much independence Europe has in the production of digital-based health instruments, machines, semiconductors. And here is the understanding of an emergency, that something has to be done. And we will see, I believe next week, that officially will come up a proposal, legislative proposal by the Vice President of the European Commission, Thierry Breton, for European supply chain regulation. If that would go through, it would change a lot. Because until now, in cases of shortages, it was business, the companies who solved that. If that would become through, it will be the case, and the Americans do the same, and others, that the state will have influence in that. How many reserves of certain ingredients and so on, not just in these medical sectors, everywhere, countries should have, companies should have, are forced to do so. Then it comes even to fine-tuning by Brussels. What does it mean for the further development of a rule-based multilateral free trading system? Or can that combine in a certain way with a security margin in it? But this can have dramatic impact. We've learned that the international system in trading was, in most of the cases, fruitful, relatively cheap, and the best places production could take place, and a fair balance or a balance between research, development, production, distribution happened. And we know that, and someone discussed it today in medicine, pharmaceutical products, not always very well. When I heard the discussion about Africa, should we build own production lines in Africa to have it faster there and so on. But on the other side, we have the discussion, can we go give it more and more to India, where most of the German pharmaceutical products are produced because of this security question. And I think that therefore, this relationship between a free trading system and a multilateral rule-based one, security needs and security beliefs, questions how the patent question And the copyright question can be put in a proper way in that context. I was 15 years ago, 20 years ago, for 3 years head of the Transatlantic Patent and Copyright Commission of the European and American industry. I've given up since then to understand that. To say, and if we find not here really solutions in that, then in such a crisis, and when we have not the clear-cut free trading system, we might get even more problems because of the threat people have seen now. We have a debate in Europe, and we had a similar debate already other places before, what we call European sovereignty. Originally, it was called, because it's broad misunderstanding, European autarky. So that in many fields, in energy, technology, ingredients, rare earths for production, the electronic questions, but also in medical questions, Europe has to come back to such a sovereign decision, not to bruise everything, but have it in a certain way under control. This is a very serious debate. It's not just a debate about politics and stronger armies. It's about these economic systems with social and medical impact. And I think it's very much important that this does not lead us to a new type of protectionism, which means higher costs for Europe and less support for a poorer part of the world. For the poorer part of the world. And here we have to find a certain combination. And I really advise us here to take in our discussion this into account and address this issue too before it's too late and these questions are not in the political arena enough seen. And therefore, I believe in this question that we should really talk to Commission and others what to do that in the European Commission, but also via G7 and G20. And Alan, perhaps it's an idea that this is also mentioned by us when we have now also in Bali the G20 debate. That is also an overall issue, which I think it's quite important, which has where the health sector is the most important, not the most important one, as many believe, but would have an incredible impact on the people. And the other point is true. Someone asked today in one of the panels why we do not react in certain diseases which does cost us more lives than Corona has done. Cardiovascular, sepsis, and all that was mentioned here. And why it was not possible until now to transport that in a proper way to the political decision-making level. It's a theory, everyone says, it breaks my heart, but an action is not taken, in my feeling. And here I think it's other question where we have to find this level of discussion. A friend of mine who has got Parkinson, and he is a high-ranking man in Berlin, in the law business, explained me now in a certain way how it can be done that within 10 years, this problem could be solved. It step 1, 2, 3, 4 is done. Should we build more on that? And because of the reasons, but because of the terrible situation of people who become ill, such illnesses, diseases. But is it not possible also to explain, and then I come to this financial point, to explain to the state, to the politicians, and therefore it's important that health and finance is discussed together. Is the cost not too high? A cost for the company, a cost for the state. If you have such diseases for some time, and what it means when people die so early, you need perhaps in business and other places. Not to say people who become these diseases cost us something, or say, how can we avoid the costs of the illness? I think ask the cost question from the other point of view, which I think it would be an important point for political debates, because this is not awareness. Politicians do not know that, no. It's not on their agenda to think it that way. And the same thing is what here was discussed in one panel, the question of metrics, finances. Alan, my teacher, and myself have discussed it in Berlin and Brussels already, and we have discussed it with the head of the International Monetary Fund. She agrees very much with this idea. On a Euro level, for example, it could be in point, we talk about the so-called European semester. The European semester means that every year, all the criteria and metrics of European economy is brought together in all the member countries in order to check whether the economy is healthy or not. And in the past, it was always in there only the classical economic criteria. Since a few years, it was possible to put into it more and more the questions of unemployment and social questions. Should this not put health in that system of importance? Make clear, and the pandemic has shown us how expensive it is when we are not prepared, that the resilience of a health system is an important measurement to find out whether the economy of a country is good or bad. So put it on this other level, not again, health costs something, but the other way around, good health policy, including in such a system, is part of the definition of the good competitive economy. And from my side, I must say thank you very much, Alan, that I could take part in that. And perhaps we can cooperate also a little bit in that question of translation, which I have tried to explain a little bit so far. I can understand these issues. I will never become an expert in health systems. In health systems, perhaps, but not in health making.
Thanks very much, Elmar. Now that I'm glad you're here, because we're going to ask you to help us with something in terms of these conclusions. You've got the draft conclusions. Now, I just want to, you can read it and you can comment on it, but I just want to mention some themes. I think it's very clear to us all, as the document says, that there's a real sense that innovation is not keeping up with the pace of the evolution of diseases. And I think that's come across very, very strongly. And that's why there's got to be greater investment in research, innovation, and product development. And so I think, as we had in the last panel, if we're going to do that, then of course we've got to have the evidence, and the whole thing has to be evidence-based if we're going to influence these senior decision makers. I thought the discussion on finance yesterday, and I want to thank you all who participated in the panels on this, I thought it was excellent. There is an issue of transparency and equity. There is an issue still of governance, and I think Bruce outlined that. And we, in this call for action, are making it very clear that we've got to have the appropriate checks and balances in the governance structure. And obviously, the citizen, in one form or another, has to be involved in this, as they are in the Global Fund. And then the point that the representative of the World Bank, I felt sort of dismissed, was the fact that there are over 35th financial intermediary funds, and we have done research on it, and some of them are not being used. And if there's only 1.3 billion in our fifth, then there's no reason why we shouldn't, perhaps through representations, through ministers, ask for at least for the World Bank to examine whether some of that money could be redeployed to the pandemic preparedness and response fifth. One of the things I want to ask you, Elma, is I know you're very close to the president of the European Investment Bank, Mr. Hoyer, and you've helped us have a dialogue with him in the past. We had a discussion yesterday on green finance, and it's still very frustrating that we haven't got financial instruments in the health sector. I do believe from the research we've done that the European Investment Bank have looked at the issue of financial instruments, of supporting financial instruments. And I would very much like to see whether within the G20 Health and Development Partnership, we can get a meeting with Mr. Hoyer and his team to see how we can kickstart an equivalence to the, I don't know what Rifat said it was, I don't know whether he's still here, but is it, I think he said $3 trillion now in green bonds. Is that correct, Rifat? So what we want really is to get, go on, yep. Yep, 3.
Yeah, that was correct.
Good, okay. To kickstart this, we need something done at a very high level, and the European Investment Bank, I think, I've been considering over the last few days, I think that's probably the place to start, because they've got the financial firepower to help us get something going there. The other thing is the health and finance ministers meetings, which this partnership actually established by our discussions with Prime Minister Abe, when, and God rest his soul. We went to see him in 2018, and in 2019, during the Japanese presidency, he agreed to host the first joint health and finance ministers meeting. Now, we still need to keep the pressure on that, but it was very clear from our discussions with the Financial Stability Board yesterday that, and you can go online, you can see what they discuss. They regularly discuss the impact of climate change on the economy, on the world economy. And so what I've already mentioned to Dr. Tedros is I would like him to write to the president of the Financial Stability Board and ask that the World Health Organization can make a presentation at least once a year on the threats to global health, which I think could include antimicrobial resistance. But I do think that if he couches it in the right way, there's no reason why there shouldn't be proper dialogue between the Financial Stability Board and the World Health Organization. And remember that FSB is made up of finance ministers and central bank governors. So we're going to continue to push that issue. On antimicrobial resistance, as I said during the panel, this is going to become a very important issue for this partnership, because we do recognize that this is a pandemic. And you see the recommendations we've got there. And you heard what I said in wanting us to work with the International Atomic Energy Agency, the World Health Organization, and others to try and move this forward more rapidly. And one of the things that James mentioned, and we've included it here, is there has to be a different sort of dialogue on how we look at the blockages, the obstacles to getting the job done on AMR. And Peter mentioned some of them when he spoke. And what we're going to create, and this doesn't need the G20 to do it, but we're asking them to support it. We will create a meeting of high-level government representatives who manage budgets, the private sector. We hope God P, Carbex, the Action Fund, and the World Health Organization, and others, and the International Atomic Energy Agency. Excuse me, because what we need to do is look at what the obstacles are. And if these obstacles are just obstacles, and we know what the solutions are to get rid of those obstacles, then we need to get action on it. So this will go ahead, and I hope that Hezbollah, before the end of the Indonesian presidency, we'll have the first meeting of that group. We do need to address the issue of sepsis. Well, bacterial sepsis in particular. You heard what Conrad had said, and we will be pushing that as part of our approach to not just antimicrobial resistance, but we'll be looking to this issue to see how, following on from the German G7, we can deal with this. Now, I want to come on to pandemic nationalism, because we've got Omar and his colleague from the United Arab Emirates. It appalled me in the discussions with Patricia Scotland in late 2020 and early 2021, and she mentioned it at the dinner last night, that many of her vulnerable countries could not get access either to diagnostics or to the vaccine. And as a result of that, it destroyed entirely the economy of some of those small nations. In the work, Omar, that we do with the Islamic Development Bank, we know from I think it's probably the same number, 57 countries who are shareholders in the Islamic Development Bank. I know from speaking at various meetings that were hosted by the ISDB during the height of the pandemic, there were Islamic countries who equally couldn't get access to vaccines and diagnostics. Yet people were going knocking on the door of the UAE and on the door of Saudi Arabia and on the door of Qatar and on the door of Malaysia, asking for money for the ACT Accelerator regime, but they weren't providing the necessary tools for the people in the vulnerable countries in the Islamic community to get access to those tools to save lives. And therefore, whether people like it or not, we will strongly support people like Omar and the government of the UAE and the government of Saudi Arabia and the government of Malaysia to create centers of excellence so that they're never exposed to this level of appalling nationalism that we saw last time. And we, a teacher and I, will be with Omar in the UAE the week after next, where we will talk to people there about how these regional centers of excellence are going to be created. And for those of you in this room who want to participate in those, then reach out to us, because we want to make sure that we don't get into that situation again. And you cannot blame countries like the UAE or Malaysia or Indonesia from wanting to have their own capacity when they were subject to the appalling denial of access to things at the height of this crisis. So we will support that. On the issue of metrics, which I know is very dear to the teacher's heart and the WIFO Institute, the German government do use metrics now to measure the return on value and the return on investment. And we want the World Health Organization and the G20 and the G7 to promote these metrics, because if we want to permanently make sure heads of government and finance ministers understand the continued value in investing in health, as Elma has just said, then you've got to be able to measure it. this is not conceptual, and that's something that we have to do lots of work on it. The metrics exist and can be modified country to country, and we will be pushing that within the G20 and within the G7, and we hope that we also hope that the World Health Organization will help us with that. And on the issue of non-communicable diseases, we obviously haven't finalized this section because we only had the discussion this afternoon. But I think a task force to develop a new comprehensive program on non-communicable diseases, possibly borrowing examples from oncology and from cancer, is a fantastic idea. And Hasbullah, I hope we can discuss this next week when we're in Bali with the T20. And I think with a comprehensive program, then I think we can do something significant. The debate we had this morning on digital health, again, there are one or two additions we need to make to this from the recommendations, but there was a G20 digital health task force set up by Saudi Arabia during their presidency. And I think what we need to do is revisit that, as Hatice suggested, and we need to make sure that it addresses the issue of equity of evidence and also the scaling up of digital interventions, so that, as we heard this morning, these interventions can actually become extremely valuable, particularly in low and middle income countries, but also as populations age, which I know will be a theme for the Japanese presidency next year. And then there's the whole issue of data and interoperability. I know there's still WHO staff here. We do need, and again, we should discuss it at the T20 next week, Hasbullah. We do need to have interoperability. We do need to have common standards, a common taxonomy, so that you can have which I thought was a great idea, so that you can have an electronic record of your data as you travel around, and it can be examined in any country that you go to in the world. But there's also the issue of privacy that we have to address. So look, there's lots more in here. Please let us have your comments by perhaps by the end of Monday. Pardon? Monday midday. Please let us have your comments by Monday midday, and we will modify it. And then what we want is for as many of you to sign this as possible. We hope that the T20, there's enough in here for the T20 to be able to support many of the ideas, if not all of them, but to support many of the ideas. And then let's see if we can take forward these and get them action. There will be the Ilona Kickbush is here. There will be the Health Summit meeting, Ilona, in Berlin in October. And what we want to do is take many of these ideas to the summit too. And as you saw from yesterday's discussion, we're working very closely with the Council of Economic Advisors, of which Ilona is one of them, for the WHO. So I've got nothing further to say on this. Hasbullah, have you got anything you'd like to add?
Just a little bit. First of all, on behalf of the Indonesian Tech World T20, would like to appreciate this great work of this GHSDP, Elmar, Alan, and Hatice, and all this staff here to organize this 2 days excellent meeting that I learned a lot. And also I have lots of ideas from hearing from you, from the discussion on various aspects that we have not thought about that before, to be submitted to the G20 presidency next week and also the coming meetings. That's really our contribution together, working together here of many public, private organizations all together. Second, I would like to also to comment that yesterday, the whole days we discussed about financing. Yes, financing is the backbone of the health system requirement. We have a lot of ideas. We have a lot of supply, a lot of materials. If financing is inadequate, then it will not be happening what we expect. That's the problem. First, we acknowledge and we appreciate our president, Indonesia, in spite of difficult times because of the Russian and Ukraine war. If I attended meeting, when I attended meeting or the government meeting in the room like this, always, the situation is very different from previous G20 meeting, because delegates from Russia there, delegates from China there, delegates from Western countries there, and the situation is not so good. In spite of that, we achieved the consensus to have VIP, Financial Intermediary Fund. However, yesterday we discussed also a lot of things, a lot of issues. It is initial fund or global fund that we expect. I read also from the beginning your recommendation. We expect more long-term sustainable fund and also adequacy. That's important. The nature of this fund is still based on donation, it's how it's called, or fundraising. Those countries who may receive the fund later on for the preparedness, again, at this time, there's only a preparedness, no fund for the buying vaccine, for example, or for purchasing diagnostic reagents to low-income or middle-income countries. But that's to prepare them. If something happening again, we don't know, then they are ready. But they might not contribute at all, the low-income countries. Maybe I'm thinking we should think about other way of financing. I was thinking that the model of social insurance, where every country contributes a portion of their GDP to the fund, and the fund will be clearly defined for what purpose, that have high externality across countries, that will be maybe more sustainable and guarantee adequacy. This is just another thinking that we have to think for the future, how we can develop this global fund that equitable, sustainable, and also adequate to meet the need for that. To meet all of the problems that today we discussed. What we discussed today is basically kind of services, situation, condition that must be funded by some fund that ensure to meet the, or maybe I can call it epidemiological needs or epidemic need instead of demand or supply. This is what is important, and a lot of ideas, innovations been raised in 2 days, and I'll be happy to convey this to the G20 Indonesia together with you, Alan and team. Thank you for all for this contribution. Thank you very much.
Hasbullah, thank you for making the journey here. We really appreciate it. And the final words to our executive director, who has worked so hard to make sure that we've had such a valuable 2 days. So Hatice, with thanks to you, you've got the floor.
Okay, I make sure we finish on the dot at 5:30. No, I think after such a great summary, thank you, Alan. Thank you, Professor Tabrani, for collaborating with us and the T20. We would also like to thank the government of Indonesia and the G20, the minister for supporting us with this event. and obviously mainly the WHO for offering us this opportunity. We're hoping that we can repeat it in the next years to come at the WHO. If you all like this platform, we will surely be having that conversation. I think the only thing that is left for me to say here is, in the beginning of my speech yesterday, I urged everyone to be open and candid and provocative in their thoughts and ideas. And I think the summary that Alan and Professor Tabrani have outlined shows that we have a lot of good ideas to work with each and all of you. And I just want to thank you for being thought-provoking, and we will make sure that we input a lot of these ideas into the call to action and make them concrete, as Mr. Brock said, so that politicians put it into actions. And I just want to remind you of my words from the beginning. I said, let's not focus only on health for all, but also health with all. And I think you have shown in the last 2 days that we can do it. So now let's put it into action slowly. And without further ado, I also want to thank my great team again. Without them, it wouldn't have been possible. And I would ask everyone to upload on behalf of my team as well. And I invite you after that to our great networking cocktail. Thank you so much.
Well, I've never had to use this during the course of the 2 days, but I declare the summit closed.